Good evening, everyone. It's a great pleasure to welcome you all for today's session, ASCO GI Updates 2026. And I would like to invite program convener, Dr. Sumit Goel, sir. He's an Associate Director, Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, Rohini, and Niti Bagh, Delhi. So, it's over to you, sir, for the opening remarks. Thank you.
Good evening, everyone. So, dear esteemed colleagues, friends, and seniors. So, we know the oncology, the way it is moving is like very difficult to keep a track of what is happening in day-to-day practice. Oncology, what we used to know and practice is changing every day. So, today, what we intend to do is we have very learned faculty, uh, pioneers in their subjects, and the key opinion leaders, the opinion of people who matter, what matters, and definitely what we learn from our seniors and colleagues, we try to incorporate in our day-to-day practice. And the foremost and the most important thing is what we see and what we talk about, how important is it for us, whether we can imbibe that into our practice, what is being done in the Western world, and how relevant is that for our practice. So, not taking much of our time. So, let's discuss about the important ASCO GI updates which were presented recently. So we have very senior people and learned people with us today. So not taking much time. So we have divided the session into two. One is colorectal, one is GI for today. In the colorectal cancer, we have three abstracts and a panel discussion by Dr. Amish Warasa. So first is Dr. Rakesh Pinati. He will be talking about FOLFIRI plus encorafenib in cetuximab in comparison to FOLFIRI plus bevacizumab. So over to you, Dr. Rakesh, for the first talk.
Good evening to all. Thank you, Dr. Sumit sir, for this wonderful invitation and opportunity and platform. So I'm sharing my slides. Yeah, welcome everyone for today's session. It's a privilege to start the session with my talk, and this is basically a review of Breakwater clinical trial. This is the primary analysis of the frontline therapy with encorafenib plus cetuximab, short form EC, in combination with chemotherapy, which is FOLFIRI in BRAF mutant, V600E mutant metastatic colorectal cancers. So very brief background, BRAF V600 mutations are seen in about 10% of metastatic CRCs. Encorafenib is an oral drug. It is highly selective ATP competitive small molecule BRAF inhibitor. We have previous study experience, and basically the published data from the Breakwater trial is a phase 3 trial that evaluated the combination of EC with chemotherapy plus or minus chemotherapy was controlled in previously untreated BRAF mutant metastatic colorectal cancers. We had already had the data that shows that the encorafenib plus cetuximab in combination with FOLFOX has actually showed improvements with respect to overall response rates, PFS, as well as OS, which is the key secondary endpoint. The discussion per today is the cohort 3 portion of the Breakwater trial. The cohort 3 had two arms, the arm D and arm E, which includes EC plus FOLFIRI versus with FOLFIRI plus or minus bevacizumab. This is a study design of Breakwater. This is an open label multi-center phase 3 study. They included treatment naive patients with BRAF V600E mutation, good performance status patients. They are randomized in a 1:1 fashion to the experimental group of EC plus FOLFIRI versus the control group of FOLFIRI plus or minus bevacizumab stratified by ECOG performance status. The primary endpoint of this experience for this trial was the overall response rates. The key secondary endpoint was PFS. Other secondary endpoints include overall survival, duration of response, and time to treatment responses and safety data. So this is a summary of patient disposition, nearly 140 odd patients, and we have a follow-up period of nearly 10 months in both the groups. And discontinuation of treatment was about 30% in the experimental group compared to 66% in the control group. In both the groups, the reason for the reason for discontinuation was progressive disease. It was 12.2% for the EC plus FOLFIRI versus 32.4% in the control group. Again, coming to the duration of treatment, the median duration of treatment was about 10 months in the experimental group compared to 7.4 months in the control group. These are the key demographic and baseline disease characteristics, more or less similar across the treatment arms. So coming to the primary endpoint of overall response rates by blinded independent committee review, the EC plus FOLFIRI has clearly demonstrated a statistically significant and a meaningful improvement in the overall response rates. As we can see, 64.4% for EC plus FOLFIRI versus nearly 40% for the control group. Most of these responses are partial responses, 60% in the experimental group partial response compared to 37.8% in the control group. Coming to the time to treatment response, it is about 7 weeks, and median duration of response was not attained in both the groups. And if you look at the duration of response of more than 6 months, it was about 57% in the experimental group compared to 34.5% in the control group. And duration of response more than 1 year was about 4.3% in the experimental group and was 0% in the control group. So this is a subgroup analysis of the overall response rates. As we can see, all the relevant pre-specified subgroups have benefited with the utility of this drug. The especially good response was noted in those patients with liver metastasis and those patients who are having a bit more worse performance status. More or less, most of the group pre-specified subgroups have benefited with the combination. This is the overall survival data at a median follow-up of nearly 10 months. The data was immature, but there was a trend towards improved overall survival with the EC plus FOLFIRI compared to that of the FOLFIRI plus or minus bevacizumab. Hazard ratio 0.49, still not statistically significant. This is the most important slide. This is a safety summary. As we can see, the permanent discontinuation due to treatment emergent adverse effects was seen in about 11.3% in the experimental group and 8.8% in the control group. In overall, grade 3, grade 4 toxicities are seen in about 63 to 70% in either groups. Coming to the most frequent adverse effects, there are no new safety signals were observed, and the adverse effects were consistent with those that were previously reported expected from the each study drugs. Coming to the dose modification due to adverse effect, as we already seen, there was about 11.3% discontinuation rates in the experimental group compared to 8.3% in the control groups. The individual drug, the discontinuation rates range between 8.5 to 9.9%. Dose reductions range between 11.3% for cetuximab to nearly 60% for the other study drugs, which includes chemotherapy, and encorafenib at around 20%. And dose interruptions were seen in nearly 55 to 70% of 60% of the patient. So these are the key takeaway points from this trial. Breakwater cohort 3 had showed statistically significant clinically meaningful improvement in the overall response rates with the experimental group of EC plus FOLFIRI in the frontline BRAF V600E mutant metastatic colorectal cancers. The early trend in overall survival was very interesting. The follow-up is ongoing for PFS and OS, and it will be reported later. This combination of EC plus FOLFIRI is generally well tolerated. The discontinuation rates are about 11.3%. Again, most of the toxicities are because of the chemotherapy. And this cohort 3 analysis of breakwater trial supports the option of FOLFIRI as a backbone in combination with EC as a potential new frontline standard of care for patients with BRAF V600 mutant metastatic colorectal cancers. It will be interesting to see what would be the subgroup analysis of MSI high, MSI low with respect to BRAF mutations, because we have other options for these patients. Interesting time to see again whether there is an overall survival advantage as well. And with that, I would like to conclude my brief overview of this discussion. Thank you very much.
Thank you, Dr. Rakesh, for your timely and wonderful presentation and very crisp and short. I am sure Dr. Amish Vora will be ready with his questions on this. So just quickly, 1 or 2 questions from my side. So have you incorporated this breakwater into your practice as of today, or you still want to sequence the beacon way? And second, how comfortable will you be using this regime versus Folfox plus bevacizumab, which we were using traditionally earlier? So your quick comments on this two things.
So you're asking me?
Yes, Dr. Rakesh, you just quick comments ki how comfortable you will be using this regime and what is your take this as compared to Folfox plus Bev?
So I think the overall response rates of 64% is very interesting, because even with Folfoxiri plus bevacizumab, we are not looking at more than 40% response rates in the traditional way we are treating these patients. So these are aggressive tumors. These are usually chemo-resistant tumors. So there appears to be a bit validity for biologically directed therapies. This is other arm of encorafenib plus cetuximab that did not had a lot of responses. So chemotherapy is definitely needed. But we need to look at the MSI high, MSI low subgroup
Yes.
analysis in this trial because nearly 30% of all BRAF V600 will be MSI high. So even the responses are there in that group of patients also, then probably there is ambiguity of choice. But if the responses are muted in MSI high, probably it makes sense to use folfoxirif plus bevacizumab in MSI high, even if there is BRAF V600 mutation. Again, for those without MSI high, MSI low, probably this is the way to go because biological therapy does have a lot of validity in this group of patients.
Okay. And so one more thing, very good. Thank you very much for the clarity of thought. Second thing is, so would you like to go the breakwater way or the beacon way? The
As of now, sir, I would
encorafenib.
probably, yeah, I'll go with the
Yeah.
beacon way as of now because there is overall survival advantage there. So I would probably
Okay.
stick to the beacon way as of today. Let's look at the outcomes in the extended follow-up period. Then probably there is a debate about toxicities and something else. But as of now, wherever there is a survival advantage, we'll probably go with that.
Okay. So, okay. Thank you, Dr. Rakesh. Thank you very much for joining us, and thanks for your. So, moving on, we have Dr. Vikas Sati from Indore. He will be talking on phase 3 commit study. So, Dr. Vikas, over to you.
Uh, so thank you, sir, for the opportunity. I'm not able to share. Wait, let me try once. I'm audible, sir?
Yes, sir.
Yes. So thank you, sir, for giving this opportunity and also giving this important, and the discussion about the Comet trial. And I will be discussing about this trial, which was a phase 3 trial of Atizo monotherapy versus modified FOLFOX6 plus bevacizumab plus Atizo in the first line treatment of patient who has a deficient MMR or MSI high status in metastatic colorectal cancer. To begin with, we know that nearly half of the patient treated with pembrolizumab monotherapy trial, that is the Keynote 177 trial, progressed within 12 months. And there are different reasons, the selection and the central testing of MSI and so on. But again, the truth is nearly 50%
Dr. Vikas,
Sir,
sorry to.
your PPT slide is not visible.
Your screen is visible, your slides are not.
okay. My screen is visible, but slide is not visible.
Yes, you just share the.
Wait, stop.
Yes.
So I will Windows, Chrome tab. I am just sharing my entire screen. No, no, or someone else from can share from that side. No
Yes,
worry.
sir, I can share.
Sure.
Okay.
I'm sorry.
Mm.
It's okay, Dr. Vikas, don't worry. It's okay.
ये पुराना लैपटॉप है सर एक्चुअली मैं घर पहुंच नहीं पाया आज.
अच्छा, it's okay. Sorry. ठीक है जी.
जी
Okay.
सर. So I will be discussing about the Comet trial, which was a phase 3 trial of Atizo monotherapy versus chemotherapy in the form of FOLFOX6, BEP plus Atizo in the first line treatment of patient who has deficient MMR status or MSI high status in metastatic colorectal cancer. Next slide, please. Next slide. So, as I already told that in the Keynote 177 trial, in which the pembrolizumab monotherapy was studied in the same group of population, around 50% of the patient progressed within almost a year. So MSI high looks wonderful, but in real sense, all the patient who has high MSI, sometimes the immunotherapy is not doing the magic. We have a preclinical data that shows that combination of oxaliplatin and PDL1 inhibitor, they work together. And also we have a phase 3 trial of MSI high colon cancer patients from uh, the adjuvant therapy, that Folfox plus Atizo demonstrated significantly improved 3-year DFS with the hazard ratio of 0.5, which is very good as compared to the chemo alone. And the combination of VGF that we are using for almost a decade, so I will not go into details. And in this study, we studies that the phase 3 trial in which the Atizo was compared in the monotherapy with the chemotherapy plus web. Next trial, please. So this is the treatment schema. Again, there was a 3 arm in this study, but again, due to the result of this monotherapy of Pembro, the web plus chemotherapy arm was closed. So what we were discussing today is the Atizo monotherapy arm versus the Folfox plus web plus Atizo arm, and there was a 1:1 randomization, and there was the 3 important pre-designed pre-specific analysis that based on the BRAF metastatic status, either liver only limited metastasis disease or extrahepatic metastasis. And the third was the prior adjuvant therapy for colorectal cancer, what they have received. Next slide. So the accrual for the trial was suspended in March 31st, 2025, after the basically the result of checkmate 8SW trial, which tested the Nivo alone versus Nivo EP, and that time the newer patient was not taken. Next slide, please. Basically, due to this, the number of patients was very less in this trial. So this was the patient characteristic in the chemo BAP Atizo versus chemo Atizo monotherapy arm. The age, BRAF status, and the tumor sidedness. Again, we can see the both the arm looks well balanced. Next slide, please. So this was the statistical analysis. Primary endpoint was the PFS, and for PFS superiority of chemo bev atizo was demonstrated with the hazard ratio of 0.439. That we believe there was pre-designed hazard. Go to the next slide, please. So this was the PFS graph, the Kaplan-Meier survival curve for PFS, the hazard ratio of 0.439, and the median PFS was 24.5 versus 5.3. So almost 4 to 5 times increase in the median PFS was there in the experimental arm. Next slide, please. And this is again we can see that the most of the subgroup appears to be benefited in the experimental arm rather than atizo monotherapy. Whether if you take the age, race, or BRAF status, again you can see the for the BRAF mutated patient the benefit was ever larger, and based on prior chemotherapy, C value, baseline tumor diameter, and the more is the tumor burden. You can see the baseline tumor more than 6 and more than 6. The hazard ratio is very impressive. So maybe in the patient who has high disease burden, this experimental arm may be better choice for the patient as compared to the immunotherapy alone. And if we see the left sided versus right sided, again right sided patients again appears to be benefited more, and we know that MSI high is more so in right sided only, but again sometimes a left sided tumor can also have MSI high. Next slide, please. So this the same thing basically depicted in the tabular manner: 1 year, 2 year PFS, 35 versus 66, and 31 versus 53. So this 1 year and 2 year respectively. Overall response rate almost double, 46 versus 86, and more CR, definitely more CR and more PR was there in the patient who received chemo bev atizo. And if you see the 1 year disease-free interval, it was also exactly double, 32 versus 64%. Next slide, please. This was the survival graph. So unfortunately, hazard ratio is almost one. But again, this is a very small study. We can't like I'm not comfortable to draw this conclusion. But at least the PFS looks impressive. Next slide, please. Coming to the adverse effect, as expected, the chemotherapy arm, the experimental arm, has more side effects, more grade 3, grade 4, and also some grade 5 toxicity was also there. So that is will be there and expected, nothing new. And also chemotherapy related side effects, something like diarrhea, neuropathy, sensory neuropathy, neutropenia, which will be there in chemotherapy, that was there in the experimental arm. Next slide, please. So apart from that, the immunotherapy related side effect was, I will say, slightly higher, but they are numerically almost same in both the arm Atizo versus Atizo plus chemotherapy and PEM. Next slide, please. I have already discussed the five total grade five. So basically, five death, one in Atizo monotherapy and more in the combination. One was due to disease progression. Two patients experienced sudden death following cycle 16 and 18. So these were basically the late deaths. And one patient developed hepatic hemorrhage post surgery. So this was the cause of five death in the experimental arm. Next slide. So to conclude, that the chemoweb Atizo demonstrated a statistically significant improvement in PFS compared to the Atizo monotherapy in the first line metastatic colorectal patient who has high MSI with the impressive hazard ratio of 0.439, and experimental arm resulted in improved complete response and also more PR and CR and less progressive disease. And the as expected, high rate of diarrhea, neutropenia, hypertension was due to web, and infection was observed in the experimental arm. And definitely, future efforts were needed to characterize a subset of patients. So this was in total, everyone who was MSI high can be randomized to one of the arm. So we need a more data, and which subset of patient will be more benefited with the addition of chemotherapy plus web. So this is all from my side. Thank you so much, sir.
Thank you, Dr. Vikas, for your presentation. Just quick question to you. Just
Sure.
we always used to discuss keynote 177, we were always worried about like the 30% of patient used to progress in initial 3 to 4 months.
Yes,
So
sir.
that was a concern. So with now this combination available, how comfortable do you think you will change your practice? Like, or you will still use this combination in select patients? And what is your take on this? Whether like what you will do in your practice based on this data? Still stick with monotherapy or combination or in selected few?
So basically, the problem with the keynote trial was that their selection criteria was, that if any loss of one gene, or I will say protein, they were eligible. So
Hmm.
in the true MSI high, there has to be loss of two, and the problem of central testing, central lab testing was there. So I think they misclassified patient as a MSI high. So that was the biggest problem with the keynote trial, and I think. With the data of the Nivo EP, which is definitely better. So maybe in a selected group of patient, I may use this data. Maybe in the patient with very high tumor burden, as you BRAF positive patient. But again, this is a small study. Um, Number of patient was less, and the number of patient that they have intended, they have to stop the trial due to they were late in. We have a data of Nevo EP, and so on. So, but I strongly feel, sir, that all MSI high patient just giving immunotherapy may not be the correct choice. We need to be more wiser in selection of therapy. But again, the time will tell how to select these subgroup of patients.
Yes. I absolutely agree with you. Not all MSI high patients deserve upfront immunotherapy. We need to choose our patients wisely, depending on the subset, like whether the patient has liver mets, etc., or not, which are poor responder to to immunotherapy alone. And Nivo IPU is another thing which we can do. But combination, definitely, we were looking for a combination with chemotherapy, which is here. But whether we can extrapolate this data, that we will, I think Dr. Amish will take up. At ESO, can we substitute it with Pembro? Though no data is there, the studies are still ongoing. And that is another discussion. Thank you very much for your time and your commitment. Thank you very much, Dr. Vikas.
Thank you.
So moving on, we have Dr. Vijay Agarwal from Bengaluru. He's a senior consultant in medical oncology. So good evening, Dr. Vijay. So he will be talking on finally KRAS G12D. We have something there. So whether to use it in combination or in as monotherapy in metastatic pancreatic ductal adenocarcinoma. So Dr. Vijay, over to you.
Yeah, thank you, Dr. Sumit, for this opportunity to talk about this very important study. I think this year's ASCO GI was excellent with some awesome papers, and this is one of those. So even though it's a phase 1 trial, sorry, I'm just trying to move this out of the way. So, oh no. So can you see my screen? Yeah, can you see my screen properly?
Yes, we can see your screen.
Yeah, so this is one of those very important papers, even though it's a phase 1 trial, looking at a KRAS inhibitor G12D. As a concept, it's been fantastic, both the data in terms of monotherapy or in combination with chemotherapy for pancreatic ductal adenocarcinoma, because we know that KRAS is mutation is quite significant in pancreatic cancer, but we've not really had any drugs that have shown good efficacy in these group of patients. So what the study actually showed, which was a molecule called INCB 161734, which is made by Insight biopharmaceutical company, showed that both in terms of when given with monotherapy or in combination with chemotherapy, it was reasonably well tolerated and had decent efficacy data, which we'll discuss both as monotherapy as well as in combination with a first-line treatment of Gem/Nab-Paclitaxel or FOLFIRINOX. We know that KRAS mutation is quite common in pancreatic cancer, colorectal cancer, non-small cell cancer, and there is some good data in non-small cell cancer with sotorasib, but we've not seen much good data with pancreatic ductal adenocarcinoma. This particular INCB molecule by Insight Biopharmaceutical is quite a novel selective oral KRAS inhibitor, particularly for G12D, which is like an on-off switch kind of a situation. The affinity for the mutated KRAS is over 80-fold compared to the white type. So quite significant selectivity for KRAS. And this was a phase 1 trial looking at its efficacy, both as monotherapy as well as in combination of chemotherapy. Basically, the eligibility criteria for this was that patients should have had metastatic or locally advanced pancreatic adenocarcinoma with a KRAS mutation of G12D type, a good performance status with no prior treatment with the KRAS inhibitor. Okay, and this was a dose escalation from 200 to 1600 milligram. There were 28 patients on that, and then a dose expansion at 600 and 1200 milligram. Where there were 25 patients with 600 milligram and 61 patients with 1200 milligram when given as monotherapy. And when combined with chemotherapy, chemotherapy combinations included either Gem/Nab-Paclitaxel, there were 17 patients on that, or FOLFIRINOX, there were 16 patients on that. And that was the dose escalation phase, and the dose expansion was done at 1200 milligrams, where there were 20 patients with Gem/Nab-Paclitaxel and 20 patients in FOLFIRINOX or modified FOLFIRINOX. The primary endpoint, as with most phase 1 trials, are to look at safety and tolerability, and secondary endpoints were also to look at outcomes, so overall response rates, disease control rate, duration of response, and PK data as well. So when we look at the patient disposition and baseline characteristics, we can see that there were about 61 patients in the monotherapy arm, 28 patients in the Gem/Nab-Paclitaxel arm, and 16 patients in the FOLFIRINOX arm at 1200 milligrams, which is what was achievable. When we look at the monotherapy, about 69%, so 42 of the 61 patients, the treatment was ongoing, and the primary reason for discontinuation was disease progression. And similarly with the chemotherapy arm with the Gem-Nab-Paclitaxel, 86% of the patients for treatment were ongoing, and in the FOLFIRINOX arm, about 75% of the patient treatment was ongoing with them. When we look at the monotherapy, the INCB molecule, it was well tolerated at 1200 milligrams as well. So only about 2%, two patients with 3% of the patients discontinued treatment due to treatment related adverse events, and about 10% had dose reductions, and about 20 odd patients, 21% had dose interruption. So not that much more in terms of toxicity. Most of the toxicity was GI related, and most of them were grade 1 toxicity. If you look at grade 3 toxicity, there were very few. Total number of toxicity grade 3 was less than 20%, with the vast majority of them being GI related. When we look at the anti-tumor activity, it was very, very encouraging at 1200 milligrams. You can see that the overall response rate was about 37%, which is what we see with chemotherapy in pancreatic ductal adenocarcinoma. And particularly second and third line, we don't even see more than 20% response rates. And disease control rate was 78%, which is again quite impressive at this line of treatment, particularly when we're looking at third line treatment. This is quite an impressive database. And when we look at the sweet spot, it is not just the response that we see, but we also see the depth of response. So a lot of the patients continues to have response 3 to 6 months later, having had the initial response. So I think the depth of response is also quite good. So it essentially shows a meaningful anti-tumor activity as a targeted therapy kind of a situation. When we combine them with chemotherapy, the INCB combination with chemotherapy, I mean, most of the times when we try to combine TKIs with the chemotherapy, we end up dose reducing either the TKI or the chemotherapy in view of toxicity. But this was not the case in this situation. The median recommended dose was about 74% for both GEM and nab-paclitaxel. So not significant dose reductions for the chemotherapy, which is comparable to the previous reports of Gem-Nab-Paclitaxel. So the recommended dose intensity was similar, about 74%. 74%. Not significant, no significant dose reduction or discontinuation for the TKI, which was the INCB molecule. Again, most of the treatment-related adverse events were GI-related toxicity, apart from the chemotherapy bit. And when we look at the combination with modified FOLFIRINOX, we have a similar pattern. The recommended dose intensity was about 76% for 5-FU, 67% for irinotecan, and 67% for oxaliplatin, which is comparable to the previous FOLFIRINOX regimes that we give. Again, very few dose reductions for the molecule itself. So I think the chemotherapy was well tolerated when combined with the INCB molecule. When we look at the anti-tumor activity, both for 600 and 1200 milligrams along with chemotherapy, we see when we look at especially the 1200 milligrams, which is on the extreme right, the overall response rate was 50%. And when we're looking at post-second line treatment, I think this is very, very impressive. And a disease control rate of 88%. So very, very impressive here. This is the data I'm talking about. 50% overall response and 88% disease control rate. And we are talking about patients who progress on 1 or 2 lines of chemotherapy. And this data we don't even see in first and second line treatment. So I think overall quite a good response. ctDNA was done to look at the molecular response, and we see very rapid molecular response with this molecule, where more than 2/3 of the patients have a rapid molecular response. The depth of response was higher when combined with chemotherapy as opposed to single agent, but nevertheless, both of them had a very rapid molecular response. So we know that this has an on-target effect and reduces the levels of KRAS mutation in the ctDNA. Some of the patients underwent clinical genomic profiling. We didn't really see much data coming out of that. Some genes were expressed, those who did not achieve response, such as SMAD4, ATM, and KRAS. Copy numbers were there, but not much in terms of the pathway evaluation. However, those patients who initially had a response but eventually started to progress, as we started to see an increase in KRAS copy number gain, which may be one of the mechanisms of resistance rather than a bypass mechanism. It is relapse of the KRAS copy number mutation again. So that is something to kind of think about, but again, small patient numbers. So to conclude, the results clearly show a favorable safety profile for this molecule, both as monotherapy as well as with chemotherapy. Very few dose interruptions and treatment-related dose reductions. GI treatment-related adverse events were the most common and mainly grade 1. The safety profile, even when given with chemotherapy, which is Gemnab, Paclitaxel, or FOLFIRINOX, remained promising without significant compromise in the dose intensity of chemotherapy. Clearly, a deep molecular response was observed in patients with adenocarcinoma of the pancreas who received this molecule in combination with chemotherapy, and not just molecular response. I think we patients had clinical response, and the depth of response in the swimmers curve was also quite significant in relevance, with the vast majority of the patients having more than 3 to 6 months of durable response. So clearly, encouraging clinical efficacy supports the initiation of phase 3 trial, and I think that is what the future direction will be. The Dawn 0303 would be a global phase 3 trial, looking at this, combining this molecule uh, with chemotherapy, either FOLFIRINOX or Gemnab Paclitaxel. And I think it would be quite interesting to wait for this data, because currently we really don't have much choices for pancreatic adenocarcinoma with not significant development having had in on terms of the molecular side. So I think quite an exciting space to evaluate and look forward to this data in this group of patients. That is it really from me. Thank you.
Thank you, Dr. Vijay. That was, as you rightly said, very impressive data and very exciting data. So probably in coming days, as you rightly said, we will see more data, and probably we'll be tempted to use in pancreatic cancer. G12D we know is one where we don't have anything to offer. So thank you very much for your presentation, and it was really wonderful presentation. Thank you.
Thank you,
Uh,
Dr.
Dr. Sumit, can I ask one, two questions to Dr. Vijay because he's not my panelist?
No,
Yes,
no,
sir. I
it's
think
a shy.
doc, up to Dr. Vijay, sir. From my side, okay. Yes, sir.
Vijay, what I was seeing that this newer molecule, KRAS inhibitor, along with chemotherapy, for 50% of the patients were chemo naive, treatment naive. So, as an ethics committee, see, I understand that all the patients are going to receive standard of care, either FOLFIRINOX or Gem/Nab-Paclitaxel, but we really don't know the long-term effect of KRAS inhibitor. If you are in ethics committee and if you have to clear this, would you do it, or you would say, okay, no, I think this is too much aggressive? There are very good institutes involved in this phase 1 trial, so we can't. They're all nice institutes. What I was seeing.
And, of
Vijay, your take on this?
Of course, Amish. I mean, I think when you're looking at monotherapy alone, it would definitely not go through. So the monotherapy clearly had after failure of chemotherapy. But when we're combining with chemotherapy, I think as a concept, it would not be unreasonable to try it as a phase 1 dose escalation.
In the
Uh,
first line, in the
in-
first.
yes, along with chemotherapy. But I think on
Okay.
its own, on its own, monotherapy absolutely a no-no. But when combined with chemotherapy, I think it's not unreasonable, honestly.
But when Vijay monotherapy, there were some responses seen,
Yeah,
and
monotherapy
there were
has.
some ongoing responses seen.
Yeah, yeah, absolutely. So I think that is fantastic data. It's something to take note of.
Perfect. Okay. Thank you so much, Vijay. Thank
Thanks.
you.
I'm really sorry I can't be for the panel. I need to rush off somewhere.
No issues. Absolutely no issues.
Moving on, I wanted to be here. He dissects data like no one else, and the way he presents and extracts information and present to us, he makes us understand in a wonderful way. Sir is a dear senior, excellent human being, and a very good academician, I'll say. And sir, over to you. And thank you for
Thank
being
you
here.
so much. I was told that of the panelists, Dr. Akanksha and Dr. Ankur, can't join. So, Sumit, can I request you to be one of my panelists, please?
Yes, sir. I will be there, sir, but I don't know anything.
That's okay. I also hardly know anything. And do we have Dr. Asati still, or he has left?
Dr. Asati sir
सर
and Dr. Rakesh
आप
Trivedi sir is
He is
there,
there.
sir.
I can
सर
hear some.
आप मॉडरेटर हो मैं छोड़ दूं
विकास तो सबसे पहला सवाल तुम्हें ही पूछने वाला हूँ रुक जा
ठीक है सर
Right. So I will try to project my slides, but if I fail, because I fail many a time, uh, I don't there. Yes. So I never write panelist this thing name because many a times it changes. Is my screen visible?
नोट एट सर यस नाउ इट्स विजिबल सर
Yes.
Oh, perfect, perfect. Right. So before breakwater, so we have four panelists. We have Dr. Abhinav, we have Dr. Ankit, we have Dr. Sumit Goyal, and we have Dr. Asati. Right. So I will go with these four people. Perfect. So Dr. Asati, while ask you one question, first point is breakwater, but when I come to your trial, 2025 keynote 177, there is a 5 years data which is published. You
यस
are
सर
aware of that. Till the time we come, I would say it's a very interesting thing. Google it, and we will discuss the breakwater first.
श्योर सर
Dr. Abhinav,
Yes,
we have
sir.
Dr. Abhinav. What do you think of this particular study, breakwater? So it's a primary analysis in the first line, chemo-naive patients, metastatic colorectal cancer, and those who have BRAF mutation positive. And this is the trial design what they have shown. That means in one arm, encorafenib, cetuximab, and FOLFIRI, and in other arm it is FOLFIRI plus minus bevacizumab. Dr. Abhinav, what do you
Yes.
think of this study?
So the trial design is good, but I am worried about, giving encorafenib, cetuximab, FOLFIRI all in one compared to the control arm, which is FOLFIRI plus bevacizumab. I think FOLFIRI plus cetuximab could have been a better comparator arm.
Or the third arm would have been FOLFIRI plus cetuximab?
Yes, yes, that could also be an option, but you're taking a comparator arm which is already not the standard of care, maybe standard of care, but a weaker arm.
Weaker standard of care. Dr.
Yes.
Sumit, in Rajiv Gandhi, right now, if you get a BRAF positive metastatic colorectal cancer, how are you treating? Because we don't have encorafenib right now, freely available in India.
Yes, sir. So the question is in BRAF mutant or all the metastatic, sir?
BRAF mutant, we are talking of breakwater, so BRAF
Okay.
mutant.
Yes, sir.
How do you treat in your OPD right now?
So OPD, very true, sir. First thing we ask the finances, the patient whether he has the access to encorafenib or not. If he has the access, we are using breakwater, sir.
You are using breakwater.
Yes,
And
sir.
if the patient does not have access,
Then whatever has been taught to us traditionally to use, if no contraindications, to add bevacizumab in the arm.
so add bevacizumab. Okay. In the younger patient, FOLFIRINOX, or every patient FOLFOX stroke FOLFIRI plus bevacizumab?
The young fit patient, traditionally whatever we were using, folfoxiri plus bev.
Okay, perfect. So, Dr. Abhinav, what you said, Dr. Sumit does not agree with that. So, because Sumit says कि जिसके पास encorafenib नहीं है, he is giving FOLFIRI plus bev as of today. Do you practice any way differently, Abhinav? So let me ask you a question. Suppose if it is a left-sided colon cancer,
Yes, sir.
RAS wild type,
Okay.
but BRAF mutant positive, would you use cetuximab in those patients? Minus encorafenib.
I think no, I will go. I mean, the downstream signaling pathway. So I think Bev plus Folfiri would be option. But here we are giving. Am I audible?
Yes,
Yes.
yes. In
Yes.
between, we
So
lost you. Huh.
yes. So I mean, we are going to use Bev plus Folfiri only, or
Perfect.
Folfox
Yeah.
Folfiri.
So I think the control arm, I think we all feel is reasonably okay right now. That is there. Dr. Ankit,
Yes, sir. Good evening.
good evening. Dr. Ankit, so control arm we discuss. Sidedness, are you little worried? Because either right side or left side का कोई concept नहीं था. They included all right and left sided.
So, yes, sir. Traditional teaching and what we follow that in our clinical practice according to the sightedness. Would have been better if they would have include and we would have to be in a better conclusion because in a right side, even if it is KRAS wild, we prefer Bevesi, irrespective of that, whether BRAF is there or not. So, I think in that scenario, in that sense, it would have been better if that would have been included, but I think in this trial also the numbers are very low, so that this might have been to
74 in each
prove,
arm.
prove
Yeah.
the concept and then take it to the maybe more numbers in further trial.
Sumit, I'm coming back to you and then to Vikas.
Yes, sir.
Sumit, assuming you have best of the lab in the world, of course you have best of the lab in the world, but assuming that you get you all the informations of the world, BRAF, HER2, and there are, we have the pathological subclassification, CPMS, CIMS, type
Yes.
1, type 2, type 3, type 4. And we know type 1 and type 3 respond to one drug, anti-EGFR, type 2, type 4 may respond to more of bevacizumab. In that scenario, do you think sidedness anymore matters? Of course, legally we are supposed to use what we are using,
Yes,
but
sir.
do you know the sidedness? Does it really matter?
Sir, that is a very interesting question and important question. Why? Because earlier days, what we were looking at in lung cancer, female, smoke, non-smoker, Asian, adenocarcinoma. So it was a surrogate basically for something. So here we are looking directly at the molecular markers. If we know what are the likely, so same or see the type 1, type 2 ultimately led to what we are likely to face in the molecular what will be the molecular characteristic of those things. That was an indirect comparison, I think. So if we have the ready-made molecular subset we know, so it will be I will be more inclined to target as per the molecular rather than type 1 type 2, sir.
Sidedness. Dr. Vikas Asati, my dear friend, are you surprised that in this trial, you see 56% patients are right-sided tumor, when 51% the control? This immediately struck my mind.
Yes,
I
sir.
said, simple left-sided रखते तो अच्छा नहीं होता.
Maybe, sir, because more right-sided tumor was there in the experimental
Yeah,
arm.
matlab it is almost, 50 versus 60 and 48 and 50, almost equal. My point is that today, assuming, Vikas, you have a patient in your OPD, which is RAS wild type,
Yes, sir.
BRAF mutation positive.
Yes, sir.
As per NCCN guidelines, you cannot use cetuximab.
Yes, sir.
But left-sided RAS wild type,
So I will give the answer, sir. You also the previous panelist you asked the same question, sir.
yeah, yeah,
So
yeah,
even it is left or right, it doesn't matter. BRAF positive, I will not use the
absolutely.
cetuximab or panitumumab. This I have
Right,
learned from Viras, sir,
right,
and he showed the Indian data. Also, he presented in ASCO
right.
or GI ASCO last year. BRAF is there. I will not use.
If HER2 is there, will you use cetuximab? And yes, then after that, Sumit.
Yes, sir.
So, like he
If,
showed some apart from KRAS, some other mutation, and HER2 was also there in that.
would you use cetuximab in HER2 positive?
I don't know, sir. I have to think, and
You
I
have
will
to think.
ask. Yes.
Okay. Sumit, you wanted to say something, and will you use HER2 positive में cetuximab?
Yes, sir. So, sir, three questions. One, sir, this study had another arm, which was only EC, which was discontinued.
Hmm.
And second thing is the right versus left-sided. I'm happy they included right-sided tumors also in this. Why? Because we want to know ki whether the BRAF, how important it is as a resistance mechanism. So whether, like, we know from data that in the first line, whether you use in the right sided, it is as good as bevacizumab. If we use cetuximab, so in this patient, whether we can break that resistance mechanism by adding encorafenib to it, that was the purpose probably in this study. Whether we can improve on the results by adding uh, encorafenib in this subset of patients. That was my take on this. And second,
So,
HER2,
right. HER2, will you use yes or no?
that we know it is a resistance mechanism. Results are not as good, but given a scenario, I may use.
You may use. Perfect. I think, it's the guidelines are silent on that.
Yes.
Dr. Ankit, the primary endpoint achieved here, 39.2% versus 64.4%. Dr. Ankit, impressed?
Yes, sir. That is in terms of overall response rate, it is good. But
Yes,
when
actually, yes. Yeah, please go ahead. Sorry, Ankit. Please go ahead.
so when you'll ask that whether you'll use it in first line or not, I think we'll need to wait more because I want to see the sequencing, which sequencing is giving more overall response, overall survival benefit.
So, Ankit, the sequences ultimately leads to overall survival, and this is the overall survival data. Um, Now, again, I would like to ask Ankit that the last sentence you used that you would like to see the sequencing. But sequencing affects OS, right? And this is the OS data. Do you think this is impressive and do you think that this is practice changing?
Sir, it is encouraging, but for me, I have still wait. I'll still go the beacon way, and we will have more longer follow up.
More longer follow-up. Perfect. Dr. Abhinav, does this OS and the primary endpoint very nice? Does it show that this is practice changing? Abhinav, if
For me,
encorafenib is freely available today.
yes, sir.
If encorafenib is freely available today,
I will reserve those for the second line, sir.
you would reserve for the second line. Sumit has already told that for him this is the practice changing. Vikas, is this data practice changing or you would like to wait for some time?
So, sir, there is a lot of censoring, in the both the arm. So, because if you see up to maybe 6 months, they are just on each other, and then a lot of censoring start. I don't know what is the reason for this.
Okay. So the data is immature, but if you see number at risk, Vikas, in the bottom
Yes, sir.
line, the number at risk are still higher. At
Yes,
the
sir.
end of 10 months, 12 months, 14 months, the median follow-up has not reached, so we can't talk about that. But out of 73 patients, even 20 patients who have still not achieved an event, uh, पासा कहीं भी पलट सकता है. But
Correct.
to me, I always get frustrated treating BRAF, whether it is right side or left side.
That is very true, sir.
I feel that this is a very interesting data. I would definitely offer my patients if encorafenib is freely available. To me, little longer follow-up of 24 to 30 months would be really, really helpful for us to change our practice. Yes, we have the Beacon study there. We also have the cricket study. We have multiple studies which is there. So we have in the second line, third line also. I personally think first line BRAF is very frustrating to treat. So if there is 24 months data, I would change my practice. That is what I would do. Let's move to the second abstract. Second abstract.
Sir, one question, sir.
Yes, Dr. Vic.
If I, sir, like majority of the patient, our patient will not, receive this molecule at least today. So my question is, do you change your decision to use triplet over doublet just presence of based on BRAF?
Yes, young patients, and if I need immediate response or early response in metastatic disease, I use folfirinox. At the same time, if the patient has a lot of fluids and TP53 positive in NGS, then I tend to use bevacizumab because either you can use folfirinox or you use folfiri plus bev. It doesn't. Both options are available. That is how I do my practice.
Yes,
Vikas.
yes, sir.
So Vikas, you presented this data.
Yes, sir.
And in the end, you said that there are some patients where I need a rapid response. I will give IO plus this thing, chemotherapy. And you said 50% of the patients in Keynote 177 relapse within 1 year.
Yes.
That was your slide. Now, I have read Keynote 177 2025 5-year follow up data.
Yes, sir.
Median OS is 77.5 months
77.5 months. Yes, sir.
with 62% crossover. And the median PFS was 16.5 months
Yeah.
versus 8.2 that we all know Keynote 177 was published long time back.
Yes, sir.
So, Vikas, aren't to me 77.9 months is a highly impressive data.
Sir, I think if we see the PFS
Yes,
was 8 versus 16.
right.
So, but again, like when it comes MSI high, we are more greedy. So it is not even one and a half, 1.5 year.
Right. So our greediness will come and we will talk about that. Uh, Abhinav,
Yes.
going back to Keynote 177, KRAS mutation where it was positive, they found the hazard ratio to be exactly 1. Here they have not included KRAS, BRAF status, so they have included. Do you think KRAS would be more information you would want, or you feel it was just one off and it doesn't matter in DMMR?
So can you repeat the question once again?
KRAS mutation positive
Yes.
in Keynote 177, the hazard ratio was 1, means chemo was as good as immunotherapy.
Yes.
Do you think here the RAS mutation information would be better?
I mean, sir, we don't have any clarity over this. Like,
Perfect.
in lung we know what mutations are there, which are the immunotherapy is not going to work. But here I don't think we have any clarity. But Keynote 177 data is good. So immunotherapy alone is an option for MSI high tumor. So once patient has a MSI high, I am going to go ahead with immunotherapy. That is
Okay.
Keynote 177. I am not going to think about all those mutations.
Understood. Perfect. I think that makes perfect sense, and that is what we are. Sumit,
Sir,
I'm disappointed with 5.3, honestly speaking. Do you think atezolizumab is a weaker immunotherapy drug?
so that is the debate which we always do. It
No,
is
in this trial, you see 5.3 months.
is
Come
nothing.
on.
So yes, sir. Absolutely, sir. It is. I personally will not use it as monotherapy, sir. It is a
So pembrolizumab, the median PFS was 16.5 months.
yes, sir.
I'm coming to checkmate 9DW, but before that, uh, we have Nivo EP data, phase 2 data, which had crossed 4 years of follow up.
Yes,
Now
sir.
we have a phase 3 data of Nivo EP versus with chemo. We have a phase 3 data of Nivo EP versus Nivo. I have not seen such a dismal results with immunotherapy alone.
Yes, sir.
Do you agree with that?
I agree with you, sir. It is very disheartening to see such kind with in MMR deficient patients. We do not well, expect. We want more.
We want more.
Mm,
No, I feel that somewhere I have lost this based on this particular,
mm.
and this is what I have taken today
Yes, sir.
morning from ASCO Education book. Nivo alone, median
Yes, sir.
PFS was 39.3
9.3
months.
months.
So, Vikas, again to you, and then to Ankit.
Sir, I agree with your comment that Artizo is a weak. It is something like you comparing Pembro XG versus Arlotinib, which is the always experimental arm in RCC trial. I agree with this, sir.
Yeah.
And that we have seen in different solid tumors, sir. not
ओके।
only here.
विकास, मैं रॉश कंपनी को तुम्हारा भेज रहा हूँ ये अभी कि
भेजो सर,
तुमने ऐसा
भेजो
बोला
सर। मैंने
है।
उनके स्पॉन्सर्ड सेशन में उनके सामने बोला था एक बार। उन्होंने बोला था कि भाई कम से कम स्टेज पे तो नहीं बोलते।
No, no. I think it's absolutely okay. Science is science. Data is data. We don't have to just speak the language people love. We have to speak science. I don't know about episo weaker immunotherapy, although I tend to believe that PD-1 inhibitors are slightly better than PD-L1. This is my gut feeling. But in this particular trial, at least Sumit, this was not justified. This data somewhere not just. Sumit agrees with that. I personally think that this particular data I do not buy, and I will not change my practice based on this particular data. That is what I would say. Ankit, do you agree? Do you disagree? And you say कि नहीं नहीं डॉक्टर बोरा धीमे धीमे बुढ़े होते जा रहे हैं. I would to change my practice.
No, sir. I totally agree with you. I think 5.5 months is even less than what we have achieved with chemo in Keynote
Correct,
177.
correct.
So I totally agree with you.
Perfect. Thank you so much. Let's move to the third one, third abstract, because I have 5 more minutes only. So this is Dr. Agarwal presented it quite nicely. In fact, KRAS G12D inhibitor is a frustration. It's a crazily frustration. Dr. Vikas, you have students also now, and you do conduct regular journal also now. So I ask you the question what I asked to Dr. Agarwal, that phase one trial chemo naive patients, would you approve as an ethics committee member a completely new drug? Or you would say that second, third, fourth line mein it is better rather than the first line?
So so basically we know that sir, pancreatic cancer is a deadly disease, sir.
Right.
So maybe I will give a thought at least if I have a good preclinical or some data. I know it's difficult. Everyone will may not favor that, but for a deadly disease where most of the patients are dying within a year, I may give a thought, sir.
Perfect. Okay. Dr. Ankit, your thought process about this trial entirely, you know.
So I think, sir,
uh,
most of the drugs comes that way only. The way you are saying that, definitely in a combinatorial approach, especially with the standard of care, toxicity with this combination is not known. So I think bringing it in second line, maybe just a smaller phase two study would have been helpful. But I don't know whether the results in the previous study or the monotherapy would have been that much encouraging that they have used this way.
Correct. So I think, like you both are thinking, I'm sure the investigators also must have thought कि pancreas में अपने को second, third chance नहीं मिलेगा. So let's try. Sumit,
Sir.
this is only monotherapy.
Yes, sir.
But this also looks quite impressive, and look at the horizontal arrows ongoing.
Yes, sir.
So
Yes, sir.
you would go for monotherapy in the third line, fourth line, or you feel that combination was justified in phase one trial?
In second line, third line, fourth line, sir, we know in pancreatic cancer patients will be very few in number, because every subsequent line there will be dropouts. And pancreatic cancer, we know it's a very aggressive disease. And if something is there, definitely I would like to use, sir, G12D. It's a frustration, sir, because nothing works. And we do not know how it works, how it will behave in pancreatic cancer, whether it will behave like EGFR in lung cancer. We don't know, sir. But if something is there, it is worth giving a shot. And upfront also, I'm not apprehensive, but in combination with chemotherapy.
Uh, Dr. Abhinav,
Yes, sir.
disease control rate of 87%, 88%. Impressive?
Of course, sir.
Of course,
For,
I know.
for a disease like you see a pancreas, it is impressive.
I know. This, what they have said, 600 mg, agar aap dekho, overall response rate is 27%, but when they increase to 1200, the ORR is 50%. Incremental dose. Sotorasib में बीच में काफी comment आया था कि 1/12 the dose भी काम करता है, and the company was pulled up for their dose, if you remember, in lung cancer. Do you think that 1200 dose should be pursued, or you think that going the further 600 plus chemo also should be pursued? We don't know how it is going to pan out. I'm just saying because I feel this quite impressive data.
So, sir, the problem with all of us is that however modern we get with immunotherapy, targeted therapy, somehow we know that at the end of the day, chemotherapy is going to save us. So that's why we keep on adding one drug along with chemotherapy.
I think you are right. Abhinav, what has happened is that मुझे लगता है कि in target therapy and immunotherapy, we are still in first generation.
Yes.
Probably when the fifth and sixth generation, which I'm sure China may be right now, targeting, they have gone to, they have proven bispecific immunotherapy, tri-specific. Now they are trying quadri-specific. What I heard that, they already have in pipeline. Till that time, chemotherapy plus combination is something which is going to help us and our patients. Abhinav, I completely agree with you on that point.
I think, sir, most
Abhinav,
of us, even in MSI high cancer, I mean, we know we start with at least 3 cycles of chemo plus immuno, then push back our chemo.
so
So this is how.
DMMR, I think you are right. I would like to give 2 cycles just to prevent hyperprogression. And that is head and neck perioperative immunotherapy has taught us, but that is for some other reason. Because if you see how many people in pembrolizumab has reached surgery, very, very surprising. So I may give 2 cycles, 3 cycles if I'm giving single agent immunotherapy to prevent hyperprogression. But Nivo-EP, I personally think is a whole package by itself and it should be studied well. Abhinav, what do you think of molecular response? We saw this, if you remember, BRAF V600E. सबसे पहला drug आया था, and we all were gaga because the disease disappeared, but within 6 months the resistance came. So हम लोग कभी भी अभी भी single agent नहीं use करते हैं because it's a very short lasting. Here there is a good and deep molecular response if you see. What is your take on that?
So, sir, as you know, we are all are evolving in all this. So, ctDNA do guide us. I mean, I haven't gone through this trial, so it is difficult for me to, comment. But if the ctDNA clearance is more, definitely the chances of disease coming back will be less.
Okay, perfect. Ankit, you agree with that point? If the ctDNA clearance is more, longer person lives, yes or no? Or maybe, I don't know.
I
Ankit,
believe, sir, yes.
you believe yes. Okay, perfect. Sumit, yes or no?
I don't know.
You don't know. Perfect. Vikas, yes or no?
So, so basically, negative predictability is very good. So if it is negative, definitely my patient is going to live long. With positive, I don't know.
Perfect. Okay. I think I really don't know. I want to believe that ctDNA clearance will make our patients live longer. Again, but it depends on what we are giving the treatment, how fast the resistance is coming up. Really, really very difficult. But with that, I close my panel, and I must say that after a long time, I had all the 4 lively panelists. Thank you so much. I think the 3 abstracts we could decipher or we could dissect a little bit. Over to you, Sumit, and
So,
thank you
your
so much for
podcast
giving me this
was really
opportunity.
amazing, sir. Podcast was really amazing.
कौन सा पॉडकास्ट ओंकोलॉजी वाला?
हाँ, वो नचिकेत वाला, सर. उसके बाद बहुत फोन आ रहे हैं, हाउ मच यू आर अर्निंग, हाउ मच यू आर अर्निंग. थैंक यू, सर.
Thank you so much, Abhinav. Thank
Thank
you.
you, Dr. Amish, sir. Thank you very much.
Thanks.
You have given us so much of food for thought. I have more questions now, which I will ask you in person. But it was a wonderful, sir. I said that the way you decipher data is wonderful.
Thank you so
And
much, Sumit.
thank you
Thank you.
very much,
Thank you
sir,
for this
for being here
opportunity.
and taking your busy time from the busy schedule. Thank you
Nahi,
very
nahi.
much, Junction. So we have a very good friend, Dr. Jagdeep Singh. So Jagdeep Singh is a
Good
senior
evening, sir.
medical oncologist and senior consultant at Amritsar. So welcome, Dr. Jagdeep. So
Good
he
evening, sir.
will be talking about phase 2 critics 2 study.
Thank
Dr. Chandra is there. I think Dr. Chandra is there. So
So
Dr.
sorry.
Chandra, I understand. It's okay.
So this,
We understand you are at a place where the connectivity is quite poor. So if you want, uh,
yeah,
so just quickly,
I'll
you
just
can. Yeah.
Yeah, quickly, I'll just wrap up that.
Yes. Okay. Okay. So Dr. Sumant, he will be talking on phase 3 study, Horizon GA01. So over to you, Dr. Sumant.
Thank you, sir. Are the slides visible?
Yes, they are visible.
Sure. So on the onset, I'm really thankful to Sumit sir for giving me this opportunity. And today I'll be speaking on something which is a very interesting abstract from the ASCO GI Symposium. It is basically a new drug which is called as zanidatamab, which has been used with chemotherapy plus minus tislelizumab for first-line HER2 positive, locally advanced, unresectable or metastatic GEA junction adenocarcinomas. This is called as a Horizon GEA01 study. So if we So basically, the key take points from the study were that this drug supports that zanidatamab as a new standard in HER2 targeting agents, potentially replacing trastuzumab with or without immunotherapy arm of tislelizumab in first-line HER2 positive metastatic GEA. So the progression-free survival and overall survival was significant, which we'll come to later. And the safety profile was consistent with the known profile of the each individual treatment. So on the background, the outcomes with standard of care first-line HER2 positive metastatic GA remains modest with a median PFS of less than 1 year and a median OS of less than 2 years. Zenit is a dual HER2 target bispecific Ig1-like antibody that binds to extracellular domain of domains 2 and 4 on HER2 in a trans configuration. So in the preclinical studies, zanidatamab enhanced HER2 internalization, reduced downstream signaling, promoting immune-mediated cytotoxicity. Tisli, we all know, is a PD-1 inhibitor, and the promising efficacy and tolerability of these combination was used in a 3-arm study. So the randomization was between trastuzumab plus chemotherapy in arm A, zanidatamab at a dose of 1800 mg for patients less than 70 kg and 2400 mg for patients more than 70 kg Q3 weekly plus chemotherapy, which was either TAPOX or 5-FU cisplatin combination. And the third arm was a triplet in which we had the HER2 antibody plus PD tislelizumab plus chemotherapy. The key eligibility criteria were basically adult patient, unresectable, HER2 IHC 3 plus or 2 plus or ISH positive, ECOG 0 and 1, and no prior treatment. Geographically, the study is quite interesting with multicentric across the globe. And after 6 cycles of chemotherapy arm, the dual primary endpoints were PFS, OS, and select secondary endpoints were CORR and frequency and severity of adverse events. So the statistical design was, it had dual primary endpoints of PFS, OS analyzed in an intention to treat population using log design. So the disposition randomization was done for 914 patients. Median follow-up was 2 years. And all the 3 arms were very well balanced with the median follow-up of around 26 months in all the 3 arms. Baseline demographics and disease characteristics were matched. Geographical regions, Asia, Europe, North America, and rest of the world, which was again quite an interesting mix-up. Disease status was taken as metastatic and unresectable. Anatomical subtypes of gastric, GE, and esophageal adenocarcinomas were separated for the studies. HER2 IHC 3 plus and PDL1 tap of less than 1 and more than 1, along with a chemotherapy backbone, as I discussed, TAPOX versus FP. So these, all the arms in all the subgroups are quite good, quite nicely balanced. So if we come to the primary endpoint, the first PFS by the BICR in the zanidatamab triplet arm versus the trastuzumab chemotherapy arm. So the median PFS was 12.4 in the triplet versus 8.1 in the trastuzumab chemotherapy arm. If we talk about the doublet, which is zanidatamab plus chemotherapy versus trastuzumab plus chemotherapy, again, the median PFS was 12.4 in the zanidatamab arm, which was quite similar to the triplet arm. PFS in key pre-specified subgroups, as we discussed, was quite interesting, except for the HER2 status, where HER2 3 plus did better than IHC 2 plus or ISH positive. Rest, all the diamonds were on the left side of the infinity. Coming to the overall survival, the triplet showed a median OS of 26.4 months versus 19.2 in the trastuzumab arm with a p-value of 0.0043. OS in key pre-specified subgroups, if we see, is again most of the diamonds were on the left side, except for the GE junction. And if we talk about the primary endpoint of overall survival in the doublet arm versus the doublet trastuzumab chemotherapy arm, again it was 24.4%, which is again very interesting, triplet versus doublet. These anti-tumor activity, if we see the confirmed ORR in patients with measurable diseases, in both the triplet and the doublet with the zanidatamab, it is quite similar, but the median DOR in months is for the triplet 20.7 versus 14.3 for the zanidatamab plus chemotherapy arm versus 8.3 for the trastuzumab chemotherapy arm, showing the advantage of the triplet over the doublet. Safety summary, if we see that the side effect profile was quite similar with this newer drug supporting a lot of diarrhea in the studies. That is why all patients in the zanidatamab arm were treated with antidiarrheal prophylaxis. So these are the common TRAIs with diarrhea being the maximum in the zanidatamab arm. Rest, all the side effects were quite similar, and I think as per the accepted side effects. Because of the diarrhea, the other side effects like weight loss were also significant in the newer HER2 drug. The treatment emergent diarrhea, so the mandatory diarrhea prophylaxis of patient in the zanidatamab containing arms was loperamide 4 mg BID for first 7 days of cycle 1 only. And as we went on further, the side effect profile and the diarrhea profile improved, which has also been seen with certain other drugs like the TKIs, that the first few cycles are more toxic than later on. So coming to the discussion, Horizon GEA-01 is the first phase 3 study in metastatic gastroesophageal adenocarcinomas to demonstrate a median PFS of more than 1 and a OS of crossing 2 years. These findings supported zanidatamab as a promising new standard in HER2 targeting agents with potential to replace trastuzumab in the first-line HER2 positive GEAs. The clinical meaningful survival benefit further supports the use of zanidatamab plus tislelizumab and chemotherapy as an important new treatment option because the DOR advantage was clearly there. Zanidatamab plus tislelizumab plus chemotherapy demonstrated a meaningful and statistically superior OS versus trastuzumab, more than 7-month prolongation. The PFS showed a more than 4-month prolongation in the zanidatamab subgroups compared to the chemo trastuzumab group. And at this interim analysis, there was a strong trend towards statistic significance OS favoring the zanidatamab plus chemotherapy arm versus the chemotherapy plus trastuzumab arm, 5-month median OS advantage. The trial is ongoing with additional OS analysis planned for the doublet subgroup now. The PFS and OS benefits were generally observed across all key pre-specified subgroups, including in patients with PDL1 tap of less than 1 or more than 1. The safety profile was consistent with the known safety profiles, and for patients who experienced diarrhea, even generally occurred early in the treatment and resolved within the first 3 things. So this is a very interesting study, I think, and as we get more data on it, I think we'll get to understand this much better. And another HER2 agent is always welcome in this subgroup, which has very poor dismal prognosis. Thank you.
Thank you, Dr. Suman, for your brief and nice presentation. Just quickly, so what do you think about like practice changing? You will change, you will discuss, you will plan?
So, I think the triplet versus doublet, I think the doublet is quite interesting. Adding of immunotherapy was only beneficial in the DOR, whereas PFS. So, I think that once we have this drug, if not practice changing, it will definitely be an added discussion with the patients as we have another drug in the armamentarium.
Thank you very much. So moving on, we have Dr. Jagdeep. Thank you very much, Dr. Suman, for being
Thank you,
here.
sir. Thank you, sir.
Dr. Jagdeep,
Good
thank you
evening,
very
sir.
much for waiting. Over to you.
Thank you, sir. So I'll share my slides from my side. So Are my slides visible and moving?
Yes, they are visible.
Thank you, sir. Thank you so much for giving me this chance to have a discussion on some of the new topics. So I was just listing some of the new drugs, new combinations. So this is another combination how to incorporate into our practice, because initially the cross protocol, then the isopac trial, then the Matron trial. Now this is another trial which we are randomizing the patient. It's a phase 2 trial, that is NACT followed by surgery versus NACT then followed by NACRT then followed by surgery versus NACRT followed by surgery. Basically, it is evaluating the pre-operative therapy, so but without any adjuvant therapy, so in the resectable gastric cancer. So it's a bit confusing. 3 arms are there and different modes of neoadjuvant chemotherapy in there, followed by surgery in each. So this is the disclosure of this study. So background coming to this study, that it's of course we have the evidence-based strategies to improve the outcome of the resectable gastric cancer, because we still know that despite all the perioperative therapy, still we are not able to achieve more than 50% in these patients. And the compliance of the post-operative therapy is low, and pre-operative treatment offers a better patient compliance, induces downstaging, and increases the R0 section in these patients. The aim of this study was to identify the optimal preoperative treatment while omitting the adjunct treatment, and it was comparing the 3 different investigational regimens. So this is the trial design. You can see it was randomized into 3 arms. The first arm was there's a docetaxel, oxaliplatin, and capecitabine into 4 cycles, sort of like a flot. And like the other arm was chemotherapy of the same, that is DOC into 2 cycles followed by the chemo radiation, just like a cross but with a higher radiation dose. And the third was the only chemo radiation followed by the surgery. So these are the details of the preoperative regimens which we're using in 3 different arms. You can see this further, that's a DOC and the chemo radiation arm. So patient criteria, again, the stage 1B to 3C resectable gastric cancer, no distant metastasis, and negative staging laparoscopy, localization within the stomach or G junction, and good performance status, and age more than 18 years of. So coming to the endpoints, the primary was the EFS at 1 year, and the secondary co-secondary endpoints were the time to event overall survival, pathological response, R0 sections, health-related quality of life, and complicated toxicity with this. So the enrollment period they mentioned is from 2017 to 2024, and basically we had the median follow-up of 40.4 months in this study. So coming to the baseline patient characteristics, we can see in all the 3 arms. So approximately a similar number of patients, close to 60 to 60, 70 patients were taken, and with a good performance status. And again, the median age was almost same in 3 arms, and the majority were from the stomach, followed by the G junction. And again, the intestinal diffuse are approximately 45 to 30% of each subset in the different. So coming to the result of the studies, you can see that patient who completed the preoperative therapy, approximately close to 81% in the DOC arm and close to 65% in the NACT followed by NACRT, and close to 84% patient completed the NACRT arm. And when we come to surgery, approximately you can see that patient approximately close to 60 patient underwent a surgery, and in arm A, 58 arm B, and 63 in arm C. And that overall, the patient who completed the treatment was 80% the arm A, 63% the arm B, because it was comprising NACT followed by NAT, maybe more toxicities are there, and again close to 78% the arm C. So coming to the preoperative toxicity, you can see the patient who had the grade 3 or 4 toxicities. So almost they were similar in the arm A and arm B. So arm 3, they had little less toxicity as compared to the initial one. So coming to the grade 5 toxicity, that was again seen in the arm A or arm B. That's more, I think it is more pertaining to the whatever chemotherapy drugs we are using as compared to the chemoradiotherapy. So coming to the results, if you see the curative resections in the patient with the arm 1, which we have received the DOC, so approximately the patient who underwent a total gastrectomy in this, so close to 48% with subtotal in the 45%, and these were almost similar in both the arms. And coming to the D1 and D2 lymphadenectomy, So you can still see the patient in the arm A, arm B, and arm C, still close to 20-25% patient underwent a D1 lymphadenectomy as compared, which is a standard care of D2 in these patients. Surgery related complication, you can see that coming to whether it's an asthmatic leak or bleeding or ileus or abdominal wound adhesions or fistula or any other intestinal necrosis, they are almost more or less similar in the arm 1 and arm 2 and slightly less in the arm 3. So coming to the results, you can see the patient who received the arm 1, so PT0 is close to 9% versus 14% in the arm D, where it was NACT followed by NACRT. And again, NACRT was only giving a close to 13%. So it means whether this radiation therapy, which was given in arm 2 and arm 3, they were almost achieving the same T0 rate as compared to the arm 1, which is giving only a chemotherapy. And while coming to the lymph node, you can again see that arm 1 was slightly lower than arm 2 and arm 3, which was a slightly numerically more as compared to the arm 1. So again, coming to a tumor regression score, so great. We can see the patient who had received arm 2 and arm 3, that is along with the radiation therapy, they have a better TRG as compared to the patient who have received only chemotherapy. So coming to the radicality of the resections, so it was more in the arm 1 as compared to the arm 2 or arm 3. And the number of lymph node nodes, you can see again the patient who received the chemotherapy, they did a better as compared to the patient who in the arm 2 or arm 3. Coming to post-operative complications, this is again, so what we were just discussing the patient of the arm A as compared to arm 2 and arm 3. So basically post-operative complications were more in the arm 1, which had received the chemotherapy as compared to the only chemo or chemoradiotherapy. Slightly numerically higher on the arm 1 side, whether it is a general or infectious or it pertaining to the, you can say, other things. So coming to the results, the event-free survival with the arm 1, that is who has received 4 cycles of DOC, was close to 68% versus 84% with the NACAT followed by NACRT versus 78% with the NACRT, and that is the arm 3. So the patient who had received this some sort of radiation therapy, they did a pretty better as compared to the DOC in these patients. So again, coming to the overall results, so arm 2 and 3, arm 3 did pretty better as compared to the arm 1. So coming to the overview, so this is the what is the 1 year EFS, which is better with the arm 2 and 3 as compared to the arm 1. Again, OS is still better with the arm 2 and 3. And coming to the perioperative complication, they were almost similar in the arm 1 and arm 3. And preoperative toxicity of grade 3 to 5 were again more on the arm 1 and arm 2 as compared to the arm 3. So considering the survival, surgical complication, the pathological response rates, total neoadjuvant chemotherapy plus radiotherapy is defined as a preferred preoperative regimen in this phase 2 study. And to summarize, this compares the 3 preoperative arm, but significant thing without any adjuvant treatment. And the preoperative compliance rate was high, 77%, and most favorable after chemotherapy alone and after chemoradiotherapy alone. And toxicity was again lowest after chemoradiotherapy alone. Surgical quality was excellent with 91% ongoing more than D1 dissection and a removal of median of 25 lymph nodes. And the surgery-related complications were acceptable, being the lowest in the chemotherapy followed by chemoradiotherapy, that is 15%. And again, the in-hospital mortality was significantly lower, and PCR was highest after chemotherapy plus chemoradiotherapy, close to 20%. And pre-op chemotherapy alone failed the EFS efficacy threshold, while the pre-operative chemo followed by radiotherapy and chemoradiotherapy were sufficiently effective. And considering a survival surgical complication and the PCR race, this total neoadjuvant chemo plus chemoradiotherapy is defined as a preferred candidate for further studies. So these are some of the limitations, because this was the current standard therapy was not a part of this phase 2 trial, and their standard therapy may change during the long duration of patient approval is going on. So take a point from this study was that if the patient, if omitted the adjuvant therapy, total neoadjuvant chemo followed by chemoradiotherapy appears as superior as compared to a chemotherapy or a chemotherapy radiotherapy alone as a preoperative regimen for the resectable gastric cancer. And this is feasible and effective and may be a topic for further evaluation in the context of organ sparing approaches. Thank you for your patience listening. So over to you, sir, and we can discuss the things based on this.
Thank you, Dr. Jagdeep. So a wonderful concept. we sometimes say we want to be aggressive, sometimes we say ki as less as possible. So we know it is a bad disease, so we want to be aggressive. So chemo plus CRT for all or for selected few?
Sir, maybe chemo, because basically all the patients are there are adenocarcinoma, so we are not contemplating adjuvant therapy. It will be very difficult to state at this point that without the adjuvant therapy, are we going to go with the same? Of course, the patient who has received the PCR are a better candidates, but who have not received the PCR or with the tumor regression score more than 2 or 3 or like that, they will not be a good candidate for the preoperative this chemo followed by chemoradiotherapy and without having the adjuvant therapy in these patients. So these are some questions which we don't have any answer, because this is like a very difficult set of trial which we are not contemplating adjuvant, and maybe those patients which we are already planned that we don't want to give adjuvant therapy, even the disease progress. I think this is very difficult to comment at this point of that whether this trial can still hold good without adjuvant or not.
Thank you very much, Dr. Jagdeep, for staying with us, for presenting this interesting data and presenting your viewpoint.
Thank you, sir.
Thank you very much.
Thank you. Okay.
So moving on, we have a presentation by Dr. Kripa Shankar. Dr. Kripa Shankar unfortunately is not able to join. So may I request Dr. Sachin Gupta? Dr. Sachin, are you there? So if Dr. Sachin, you want time, so I'll present Dr. Kripa Shankar's slides. But if Dr. Sachin, you want to present first, you can go ahead.
I am there. I can.
Okay, so I'll not keep you waiting. So if you are ready.
Everything in this expert discussion. So I'm too timing. There is another webinar going on. Chandragouda was also there.
Okay, so if you want me to present, I'll present.
No, I'm okay. I think I'm done with that.
Okay, okay.
Yeah, so we can go ahead. So can I share my slides?
Yes, please.
Thank you, Sumit. You have put up a very wonderful webinar today. But I could listen to only few of the abstracts and the part of the panel discussion by Dr. Vora, but because I was, occupied in something else also. Let me just share my slides. Okay. Can you see this?
No, sir.
Yes,
Yeah.
now
No?
visible. Yes.
Make it full screen, please.
Okay. My Okay, now full screen?
Yes.
Got it? Okay.
Yes.
So this is about phase 2 illustro trial of first line zolbetuximab plus chemo and immuno. So this is nivolumab here. So these are patients who have claudin 18.2 positive, locally advanced unresectable or metastatic gastric and GE junction adenocarcinoma. So, after this drug has arrived and, a lot of things are happening in gastric cancer. So gastric cancer used to be a very, depressing malignancy to treat and for most of our career so far. But now there is so after lung, after GI, cholangio, so there is some renewed interest in gastric cancers because we have some wonderful drugs now and a lot of things are happening here. So the takeaway points are in the beginning, and so what we see here is, so this is leading to a encouraging PFS in cohort 4B. So we'll be coming to these cohorts, and so median PFS nearly 15 months, and with high claudin 18 it is 18 months, and with claudin plus PDL1 positivity it is going close to 2 years. So which is something unheard of in gastric cancers, and also it showed an acceptable safety tolerability profile. So this is a promising treatment strategy for HER2 negative patients who have claudin positivity and who also have PDL1 positivity. So now this is going to a phase 3 Lucerna trial, So where this hypothesis would be tested in a broader way. Okay, slide is not moving. Okay, so giving the background, so first line biomarker driven therapy is a standard for patients with gastric and GE junction adenocarcinoma. Now, Claudin 18.2 is a validated target in nearly up to 40% of the patients. And so there was a phase 3 spotlight and glow studies where this drug, along with chemo, improved PFS and median OS compared with the chemotherapy alone. So these are the figures here, 9.2 versus 8.2 and 16.5 versus 13.5 months. And in preclinical models and on treatment immune profiling, Zolbi plus chemo showed synergy with PDL1 inhibition as well. And so now the triplet therapy tested in mouse models, and Zolbi demonstrated immune microenvironment remodeling with increases CD8 plus T cells and CD163 plus macrophages in on-treatment samples from patients. So now this phase 2 Illustro study investigated the efficacy and safety of Zolbi along with chemo and PDL1 inhibition. So this is cohort 4 design where untreated locally advanced GE junction and gastric cancers were included. Now Claudin 18 was stratified to moderate to strong staining in more than 50% of tumor cells. So intermediate when 50 to less than 75%, and high where it is more than 75% of the cells. So these patients were HER2 negative. So anti-HER2 was excluded here. And so for first 4 cycles, Zolbi, so there were stratification of dose with 600 oblique 400 or 800 oblique 400, along with nivolumab fixed dose 240 and Folfox 6 line was used. And subsequently after this it was changed to Zolbi with nivolumab, and 5-FU leucovorin was continued. And this cohort B is the expansion phase for 65 patients, and where finally the dose of zolbetuximab used was 800, and along with nivolumab and Folfox. So endpoints were PFS, overall response rates, disease control rate, duration of response, OS, safety, and tolerability. So 12 patients in 4A and 65 patients in 4B. And so these are the statistical considerations. Assuming 12-month accrual and 3 to 6 months follow-up, 20 to 25 PFS events were expected, and sample size was estimated to provide 70 to 76% power to detect a PFS improvement, with the assumption of a median PFS of 12 months versus a median PFS of 8.5 months. And so this is the cohort 4A for 12 patients. So let's concentrate on cohort 4B, where there were finally 71 patients who received zolbetuximab 800 milligram per meter square, and nearly 50 had discontinued, majority due to disease progression or some adverse events and death. And at data cutoff, nearly 21 patients were taking zolbetuximab. So these are the demographics. Median age is 61, male female 62 versus 38, and Asian nearly 79%, and previous treatment surgery or surgery followed by chemotherapy or chemotherapy followed by surgery could have been there in few patients. And primary side was stomach in majority of the patients, G junction in about 13.5% of the patients. And majority of these patients were diffuse type, and then smaller number were intestinal and mixed. And if we look at the Claudin expression, 60, so majority patients, 85% had high expression, and PDL1 status was about 2/3 had PDL1 CPS more than 1. So now coming to the PFS. So median PFS nearly 15 months in this triplet regime. And so we can look at this curve here. And if we look at stratification by expression of Claudin, so for high Claudin, so the median is 18 months versus 6.7 for intermediate. So now this is the differentiating point at high. So this is kind of a predictive marker. And if we look at PFS by PDL1 and Claudin high, again the median PFS is even higher. So this is close to 2 years. So this gives us a fair idea that both things together are making a huge difference and a significant difference here. And the OS stratification by Claudin expression, for high, the median OS is not achieved versus 9.6 months for the intermediate one. And tumor responses, here we can very well see that for high, so the blue bars are high Claudin and high CPS. So these patients are benefiting the most. And the green ones are high Claudin but less CPS. Again, they are also benefiting somewhat. And these are the anti-tumor responses over time in cohort 4B. And so the green dots are for CR, the red dots are for the partial response, and the arrows are for the ongoing treatment as well. So some of these patients are still ongoing treatment at 2 years. So coming to safety profile, and so the adverse events leading to discontinuation, nearly 50%. Zolbetuximab discontinuation nearly 5%, nivolumab discontinuation nearly 8%, and Folfox component, if you see, the nearly 35% discontinued oxali, and about 26% discontinued 5-FU bolus. And there was some dose adjustment of zolbetuximab in a very small fraction of patients. Now, if we look at the grade 3 and more adverse events in more than, let's say, 20% of the patients. So here, decrease appetite, neutrophil count, decrease peripheral neuropathy, some vomiting, diarrhea, anemia. So all these things were there. And of course, majority of these events were ascribed to chemotherapy. So to conclude, the triplet therapy with Zolbi plus Folfox and Nivolumab led to encouraging PFS in this phase 2 study Illustro. Median PFS 15 months and PFS favored with high Claudin 18 and high CPS more than 1. Response rate 62% and 68% with the higher Claudin positivity. So this demonstrated acceptable safety and tolerability profile as well. And there were no major new safety events ascribed to this particular drug, and triplet therapy approach may represent a promising strategy for these kind of patients. And so this suggests that so it's not available, it must be very costly, but this shows us a further way of treating these kind of patients, and we are sensitized to doing Claudin marker also in these patients apart from MMR and HER2 new and PDL1 we are doing already. So this will lead to a phase 3 Lucerna study design, where again HER2 negative, Claudin positive patients and PDL1 positive patients are going to be included. And so Zolbi, and so here another, so it is being studied along with pembrolizumab here. So that's the difference, but this is a very exciting time for treating gastric cancer patients. And this trial is funded by Estelas Pharma. I think I'll just stop here. Thank you.
Thank you, Dr. Sachin, for your presentation. So just one quick question. I know we are running late. Just one quick question that is, these are new drugs for us and we do not know how to use them. Our understanding is poor as of now. So what is your take on combination of these drugs, whether it will be practical or it will be like quite some time before we use them and we get used to them? And
I think this phase 2 data is quite robust. It's not just and the differences they are showing is, and if we compare with other, let's say, historical data with other drugs and other situations, so in gastric cancer these responses were not seen earlier.
okay.
Going to 2 years PFS and things like that. So I think these things are definitely improving. And of
I
course,
think
there would be cost limitations, and it will take many years before they become really available, and also, our patients can afford them. But definitely things are going to change. And the next era is of these kind of drugs. So ADCs and uh, let's say bispecific and targeted therapy.
the
So all
different
these
combination.
combinations are going to happen. This is inevitable.
Yeah. Yeah. Thank you very much, Dr. Sachin, for taking your time out and presenting this and giving us your viewpoint and thoughts on this.
Dr.
Thank you
Sumit,
very much. Yes, Dr. Sushant.
I have a question to both of you, Dr. Sachin and Dr. Sumit.
You are the moderator, boss.
Uh, no, just the question is that Claudin 18.9 about
18.2.
18.2, two or three of my patients have come positive.
Okay.
And I, after progression, I told them to have this drug and they were willing to have this drug.
Hmm.
But when they consulted the Western population doctors from US and UK,
Hmm. Hmm.
they were discouraged. They were told that it's not very uh, advantageous to use this drug and may not be helpful. And so they were discouraged from using this drug. So I
Hmm.
want to know the Western counterparts, since you have been dedicated so much into gastric cancers, has in international conferences, has anyone shared their real life data or anything real world experience of using this drug?
So that's
Because
what I
two or three
asked.
of my patients have been discouraged by Korean doctors or by American doctors or by UK doctors that you may not
So that's
find
what
it
I
very.
asked Dr. Sachin. How relevant will it be? Like
So,
we don't
the
know.
drugs, so these drugs, so once we, gastric cancers, gallbladder cancer, so these kind of cancers have very dismal prognosis most of the times. And when we use these drugs in third line, fourth line, fifth line, so you get dismal responses. A very small fraction of patient would get a meaningful benefit of, let's say, 6 months, 1 year. So those patients are rare. Once they move into front line, they can be a more, give a more, let's say, durable kind of a benefit and response.
Okay, I
So
think
if we look at the other data when this zolbetuximab came, so it was tested in the later lines of treatment, and there it gave, I won't say a very great benefit, but then there was something where there was nothing. This is
I
how
think
the science moves, and these drugs move in the front line subsequently.
I think we had a trial at RGCI which is closed both in second and third line. So, but that study is no longer there. So we don't know ki, let's wait for the results to come and see what is like the real world evidence and how it performs. Thank you very much, Dr. Sachin. I think in the interest of time, Dr. Kripa Shankar is not there. We will move ahead. So next is Dr. Shaina. Dr. Shaina will be presenting on S1 Ox versus uh, the capital study versus S1 in the adjuvant gastric study. Over to you, Dr. Shaina. Thank you for staying so long and for waiting. Thank you very much. Please go
Good
ahead.
evening, sir. Thank you for the kind invitation. Uh, I'll share my slides. Uh, is it visible? Could you please confirm,
Yeah,
sir?
yes, it is visible.
Thank you. So this is an interesting study from the East, actually, where what they do mostly is an upfront surgery for most of their gastric cancer patients, and then go ahead with the adjuvant chemotherapy, which is different from what we follow and the West follow of using a perioperative regimen. So this is an adjuvant oxaliplatin with S1 versus S1 alone in patients with stage 2, 3 gastric or gastroesophageal junction adenocarcinoma, a capital study, a phase 3 trial. So, like I said, there has been a different oncological principles being followed, comparing the East and the West. And so what they've been doing in Asia is surgery, where the surgeons do a very aggressive surgery and D2 lymphadenectomy has been a standard. Then they use adjuvant chemotherapy, that is 12 months of S1 or 6 months of Capox. has been widely used as standard of care in these stage 2, 3 gastric and G junction adeno. But they felt there is always a room for improvement as only S1 monotherapy is being used. So this was a study where they added oxaliplatin to S1 and see whether it would do better than giving S1 mono. A phase 3 trial, they randomized patients who were operated pathologically stage 2 and 3, 18 years or older, undergone D2 gastrectomy, and randomized to SOX regimen for 6 cycles, followed by S1 for 10 cycles. So total of almost 1 year of therapy versus S1 alone for 6 cycles. And primary endpoint was overall survival. These are the baseline characteristics, and these were well balanced in both groups. The tumor location we can see is mostly the gastric cancers, less of G junction. Most of them stage 3, T3, T4, 88%. And node positive also, it's N2, N3. So these are locally advanced diseases what they had. And among the histology, there were around 30%, 25 to 30% signet ring cell histology. Coming to the overall survival results, they found that there was a statistically significant improvement in OS with adjuvant SOX versus S1 monotherapy, and the hazard ratio of 0.74, a 5-year follow-up data showing an overall survival of 70.9 versus 62.9%. So good absolute difference of outcomes which we can see at a 5-year follow-up. So this forest plot also shows that almost every subgroup favored use of the SOX regimen. And the DFS benefit was also observed with adjuvant oxaliplatin in addition to S1 versus S1 alone. 3-year disease-free survival of 71 versus 65%, and 5-year disease-free survival of 66 versus 55. So 11% difference. So adjuvant SOX reduced the relapses, particularly the loco-regional relapse. So if you look at this, the hematogenous relapses were almost similar in the two groups, but the loco-regional relapse was definitely less in the group which used an intensive regimen. The side effect profile, as expected, with the use of oxaliplatin, the cytopenias were slightly more. Neuropathy was seen in these group of patients compared to S1 alone. But overall, these are manageable side effects and comfortable with the use of oxaliplatin. So conclusion, addition of oxaliplatin to S1 significantly improved the overall survival and the disease-free survival in this subgroup of patients who've been operated at stage 2, stage 3 G junction and gastric adeno. It was consistent across all subgroups and adverse events were manageable. So the capital trial supports the use of SOX regimen. My take on this study would be that, like I already mentioned, we have not been following, means we prefer to follow the perioperative regimens when it comes to clinically T2 or node positive disease. But I think this could probably help us to understand the use of S1 drug in gastric cancers, which is now upcoming, especially with now studies comparing, there's one more study in which they're trying to add immunotherapy drugs to SOX regimen in peri-op setting. So probably for us, that could help us in thinking of using this regimen also for our patients, or even in the adjuvant setting where we use Kepox as per the classic trial. But overall, won't change much of our practice because we follow the peri-op setting more. Thank you.
Yeah, thank you, Dr. Shaina, for your presentation and for your take on this. So just one quick question. One, see, we understand that we are into using perioperative therapy in majority of our patients. And radiation we rarely use. If D2 dissection has already been done, we don't use it. The second thing is, we know sometimes patients, they get surgery done outside and we are usually stuck whether to give adjuvant or not. If yes, to give what? Probably in that setting, maybe we can use it. But the other question is this, they have used it for 1 year. That traditionally what we do is we use 6 months of perioperative or 6 months of adjuvant treatment. So here they have used 1 year of adjuvant treatment. So any thoughts on that? Why so?
Yes, yes. So like I said, like what we've been using classic trial. So instead of that, yes, this could be one of the regimen that can be considered, because yes, in India, a lot of patients undergo surgery and come to us for all the practical purposes. But for duration, I'm not sure, but what I read up is they have been using 1 year of adjuvant S1. So probably that's why in this study they took 1 year. But whether if we compare it with 6 months of Kepox classic trial, I don't think we have any study of head-to-head comparison.
And also, we are not likely to get it, but probably it was the micrometastasis or the prolonged. So rationality we don't know, but they have used. So it would have been better if they would have used another arm of 6 months or shorter duration, probably.
Yes, sir. Yes.
Okay. Thank you very much, Dr.
Thanks.
Shaina. I think we will, let's move quickly to the last part of the session, which is a panel discussion. Panel discussion by Dr. Sushant Mittal. So, Dr. Sushant, over to you.
Thank
Good
you,
evening,
sir.
Dr. Abhishek. Good to see you.
Good morning, good evening, sir. Thank you for the opportunity. And
Yes.
it is definitely very good to see you again.
Dr.
Good morning
Sushant,
to all
over
the
to you.
panelists.
You are the
Yes,
boss
sir.
now.
I'm just sharing my slides.
Shushan sir, Dr. Kripa Shankar is not there. Rest panelist is there.
Okay. I thought we were running behind schedule, so I didn't thought.
Yeah, we are behind schedule.
I thought few people are there before me for the. Just hold on. Just give me a couple of minutes. So my slides are visible.
Yes, sir. Make it full screen.
Just a minute. Is it full screen now?
Yes, sir.
Great. And how do I see my panelist? Okay. How do I see my panelist?
Sir, your panelist is Dr. Jagdeep sir, Jagdeep Singh sir,
Good
Dr.
evening,
Sachin
Dr.
Gupta
Shant.
sir, Dr. Abhishek Agarwal, and Dr. Sheena Goyal.
So just four of them: Dr. Jagdeep,
Yes.
Dr. Abhishek, and Dr. Sina.
And Dr. Sachin Gupta sir.
Oh, okay, fine, fine, great, great. Okay, layout. Okay. So good evening, everyone, and thank you, Dr. Sumit, for giving me this opportunity. And we'll be discussing about optimizing the treatment of gastric cancer. So, Dr. Jagdeep, uh, how often do you see resectable gastric cancer in G junction?
So good evening, Dr. Shant. So close to 45% maximum. So still majority land with the metastatic settings.
Mm-hmm.
And in that metastatic, you can see like 15 to 20% close to who are found to be having laparoscopic disease may not be visible on the imaging or scans, but in toto, who are a fit resectable patient who fit into that category is close to 40% maximum. This is what I feel in my practice.
Dr. Sachin? Dr. Sachin Gupta, you
Yeah,
there?
Sushan. Yeah,
Anji.
I'm there.
Yes, sir. Yes, sir.
It's dinner time. Things are getting too delayed. Everybody's
Anji.
after my life here.
Okay. I'll finish it off fine.
Yeah, I think we should finish it very quickly.
Yes, sir. Yes, sir. Sir, how often do you see resectable?
Yeah, so we do have resectable patients, and in last few years we have been doing many times this perioperative therapies,
Mhm.
and so it's not a that rare thing. Maybe because of better diagnostic facilities and more availability of hospital and doctors, so early gastric cancer has is becoming more common than what we used to see 10 years back.
Fine. Dr. Abhishek?
Hello, I am audible.
Yes, sir. You're audible, sir.
Hmm. Hi, Dr. Shan. Nice to see you.
Same here, sir.
So if you compare G gastric cancer and G junction, so probably G junction is which have we seen more as resectable. Definitely, I think
Sir, your voice is cracking, sir.
G junction probably higher. Am I audible now?
With great difficulty.
Is it better now?
Little better, sir. Little better. Dr.
Just give me 2 minutes.
Yes, sir. Dr. Sheena.
Good evening, sir. Sir, if I may please correct, this is Shaina.
China.
So, sir,
Sorry.
I agree with what my colleague, other panelists have said. I think it's around 40% operable. And yes, we have been seeing more number of cases. I think if we increase it to the locally advanced also, it could be higher, maybe 60% of these patients whom we are able to try for perioperative and surgery. So, I think it's a good number of patients whom we are offering perioperative nowadays.
So if I say 40% of the patients nowadays we are seeing resectable gastric cancers, so are you or your surgeon is doing staging laparoscoping all or only in high risk patients?
Sir, mostly all of the patients, because if we discuss them in the tumor board, we do offer staging laparoscopy as indicated by the guide, matlab as said, as per the guidelines, we do it.
So Dr. Abhishek,
Yes, for staging laparoscopy, I'll agree. We do it in all patients. All
you do.
patients should undergo staging laparoscopy as far as gastric cancer is concerned, and
So
even G junction.
so Dr. Sachin and Dr. Jagdeep, you agree that your surgeons and tumor board they agree to.
So fortunately nowadays we are having a good MDT, and we don't have a much of the surgeons who are operating at the upfront. So what Dr. Shaina and Dr. Agarwal said, it's correct. So all the patients, because we don't get usually stage one, I don't see. Honestly, I have not seen from last 2 years. And majority are either stage three, they are in form of some nodal disease, and laparoscopic, they are negative. So by default, all the patients are subjected to the staging laparoscopy in those.
And so along with staging laparoscopy, do you do PDL1, HER2, MSI, Claudin 18.2, or any other
So,
changes?
if you ask me PDL1, yes, I should prefer right now when we are having this long peak of Matterhorn, which you presented in your first slide. That should be ideally yes right now at this point of time. MSI, I may not be doing at the upfront. Her to know I will not do until it is a metastatic. Claudin I will not do if it is a first line, even metastatic also I will ask for, but I will utilize if required in the second line therapy, not in the initial first go setting.
Sachin Gupta? Dr. Shaina, are you doing these tests?
Uh, Sir, routinely not, but yes, we have data on doing MSI high because of the role of peri-op immuno and all that is coming in. But as of today, not doing it actually in practical. Yeah.
So have you have any idea or have you have any data regarding the prevalence of PDL1 in Indian scenario?
Yeah, sir. So there is data of PDL1 prevalence. I think there's a study a couple of years back which shows around 40%, 35 to 45% PDL1 prevalence in Indian setting.
Okay, and Dr. Jagdeep,
Exactly figure I cannot state, I'm not sure also.
but roughly,
So close to what Dr. Shana, close to 20 to 30% patient should be PDL1 positive. That's what I feel. So what she said is right, quite right, because MSI high, if you do, you can incorporate immunotherapy in the patient who are not fit for a flood type of therapy. That's correct. But right now, not doing MSI in the resectable, that is non-metastatic. I'm not doing.
so Dr. Abhishek, in early stage gastric cancer, what is the discussion happening in your MDT?
So actually, it is very difficult to see an early stage gastric cancer. But if we do see one,
I
definitely
would say operable gastric cancer. If it, what is the discussion which happens?
if it is like early stage, you see by if you see by definition, early gastric cancer is the tumor which is only confined to submucosa. You know, T1A or T1B lesion. So, but that is very rarely we'll see such kind of lesions. But if it is operable gastric cancer, we still, if patient is doesn't have any obstruction or doesn't have any bleeding, we'll discuss neoadjuvant therapy followed by surgery. That is the usual plan for
Okay.
a T2, T2 or a node positive lesion, T2 high, T2 or more, or a node positive lesion.
So, Dr. Jagdeep, in your MDT, surgeons do agree that in resectable gastric cancer, perioperative chemo is required, and they're convinced about the data.
Yes, yes, sir. Because fortunately, my surgeon is from TMH, so
Okay,
he's okay. What the literature states.
literature
So
says.
if we encounter general surgeons, usually, honestly, no surgeons concur with us. So they will do surgery only, then they will sit. And even sometimes I face a challenge with some of
Patient
my
will not go
gastro
to the
surgeons
MDT
also.
itself.
Yes, sir. That's true. True. So even gastro surgeons are not convinced.
Yes.
They for the NACT or
I am a
perioperative therapy.
gastrosurgeon. I am quite convinced. I
Oh,
am
No,
a
Dr. Abhishek is a
gastrosurgeon.
gastrosurgeon, I know. That's why I asked him
but
in his MDT what is the discussion which happens. And I know he goes by the data, and I know that he prefers perioperative chemotherapy. But my question for Dr. Jagdeep is because he's practicing in an Amritsar, and obviously
Yes.
he is in a place where he might be getting references from other surgeons that we have done the surgery, now you take over, you decide what is to be done.
so
That is why
what,
I asked.
sir, the honest thing that we do get patient, then we are only left with either Capox or Folfox in adjuvant setting, which we always do. So the thing, but the patient who come upfront from the gastroenterologist, all 100 patients from last 2 years, we are doing MDTs. So because surgeon is he's well versed with the data, so with the literature,
It becomes
so
easier for you.
we go with that.
Dr. Sachin, are you back online, sir?
Yeah, I'm there.
Sir, so in your scenario, in your MDT, the resectable gastric cancers, do you routinely follow perioperative chemo?
Yeah, so most of the times we'll be using, especially because now with the advent of use of immunotherapy, it has become even more exciting. The benefit is even more expanded. But even earlier times, perioperative was there. For many years we have been doing perioperative. Before this flawed, only flawed. Before that, we have been uh, using like 5FU based PCF or other regimens we have been using.
McDonald's regimen and all those things.
Yeah.
Mhm.
So it is already there for I think many years now.
Many years, and it is being followed. And I think
Yeah.
Dr. Shaina, what's your take about that?
Yeah, sir, I think same here also that we've been following perioperative chemo. ECF was what was being used earlier, then it came to FLOT. And now in our tumor board, we definitely have discussions regarding use of Materon also. But we've been using perioperative chemo.
So now the question which arises is that in resectable gastric cancers, the purpose of giving neoadjuvant therapy is not to make them resectable, it is to improve the PFS, it is to improve the OS. We already know that these patients are resectable upfront also, but giving the new adjuvant increases the PFS and the OS, and that is what the perioperative plot has demonstrated, that there is an improvement in DFS and OS, which is a standard of care, which we all agree. I think uh, the cross trial data has also been compared to FLOT, and which shows that the 3-year OS data, 5-year OS, 3-year PFS, all are superior in terms of giving neoadjuvant chemotherapy versus cross regimen chemoradiotherapy. Dr. Jagdeep had also presented one of the papers in the beginning, and we believe that the chemotherapy is still upfront to be given compared to CTRT. Now, is there, Dr. Jagdeep, this question is for you since you presented. In which patients do you prefer NACTRT versus perioperative FLOT?
So with the today's data in adenocarcinoma, I am convinced with the perioperative FLOT. But if you ask me still to choose, could be patients with some squamous adenosquamous pattern or squamous type histology. I'll still go with the radiation therapy. And of course, the patient post NACRT means what you said initially, that it is not that they are unresectable. They are basically resectable. We want to get improve their survival.
Yeah.
So I won't say that patient who will be having a positive surgical margin, because if it is unresectable, it will always remain unresectable. Stomach usually does not get changed to a resectable once it's unresectable. This is what I feel. Or maybe those patients who are not a good candidate for the flood-based therapy, that is one thing, old comorbidities are there. So those patients, I can still give us some sort of a cross-type regimen to get the resectability.
So Dr. Abhishek, since you are a surgeon, where in squamous you want us to give NACTRT followed by surgery, or in adeno also you want us to give NACTRT or just NACT?
So for lower end adenocarcinoma, type 1, type 2 is basically treated as stomach. So there is no question about type 2. Type 2 is definitely flawed. But now, even with lower end adenocarcinoma, we were using flawed. For squamous cell carcinoma, definitely neoadjuvant CTRT.
Neoadjuvant CTRT. And I,
For
Dr.
lower end
Sachin,
squamous, yes, not.
so, sorry, you were saying, Dr.
Yeah,
Abhishek?
yeah.
Yeah, I just completed. I said for squamous cell carcinoma, definitely neoadjuvant CTRT. And for adenocarcinoma, even for type 1, we are now preferring flawed.
Sir,
So,
Dr.
Dr.
Sachin.
Sushant,
Yes,
Yeah,
sir.
yeah.
so basically, like, Dr. Abhishek, your take on this. So basically, we have cross protocol also, which included G junction tumors. So if the patient is like having a 5FU, we feel the patient is not fit from cardiac perspective, may have low this thing, or is not able to tolerate 5FU or FLOT or intensive chemotherapy. Probably there, will you be tempted to use cross protocol? G
Definitely, sir.
junction
If patient
tumors,
is not
adeno.
obviously like if patient is not fit for float even in stomach, then we use Folfox. So definitely if patient is not fit for float, then definitely it's better to do cross
For
rather than
G
directly going
junction,
for surgery.
not gastric. But because in cross also there were 70% of the patients who are
Adenocarcinoma, definitely. So
adenocarcinomas.
definitely it is a
So
very good option when patient is not fit for float. That is true. That is absolutely true.
So I think all of us would agree that NACTRT for squamous cell, and other than that, in adenocarcinoma, we want to give FLOT, that is NACT. And now the question arises, how can we improve by giving IO? And we all know that PDL1 is found in 40 to 60% of the gastric G junction tumors. And as Dr. Shaina and Dr. Jagdeep said, that about 40% of these patients have PDL1, and high PDL1 has a poor prognosis, as we can see from this Korean study, that they have lower survival because of the pathophysiology, which we all know very well. So, any of us have used perioperative chemotherapy? Dr. Sachin, have you used?
Yeah, so I have used this Matterhorn in one patient.
Okay, sir.
And so this was an elderly man. So we gave Flot plus durvalumab, and this patient had pathological CR also.
Okay.
But subsequently, he was not tolerating 5-FU, so we had to drop. We have to tweak the regimen a bit in the adjuvant setting. So one good experience with this, but that's it.
Dr. Shaina, have you have any experience perioperative?
No, sir, I have not used for any of my patients till now.
Dr. Jagdeep,
No, sir. Still no hands-on experience.
Dr. Sumit,
No, not yet. I have not used.
not you, sir. Dr. Abhishek, since you are in a center where a lot of affording patients are there, any of your
Yeah, yeah, but like actually, but recently we have like we did routinely we did PDL1 testing for neoadjuvant setting, but none of the patient actually approved for dual. They could not afford. Even in my center, they were not agreeing. Recently, only yesterday only, I had one patient. We has received one cycle of flot, and we kind of tried to convince him to take durvalumab, but we have not been able to use it till now.
not able. So very limited experience across North India, and we have tried various immunotherapy. Pembro has been used; it's a negative trial. Atizo, the data is still awaited. Then Nivo, it's a negative trial, but Matterhorn, which was a study in which Durva along with Flot versus Flot was used, and we had the primary endpoint, which was EFS, was uh, uh, significant enough. This was the study design, and patients which were operable, that is T2, N0, N3, or T0, T4, N1, N3, M0, with good performance status. Asian population was also there, and PDL1 expression with help of TAP score less than 1 and more than 1 there, and neoadjuvant Durva plus Flot, followed by surgery, followed by Durva Flot for 2 cycles, followed by durvalumab every month for 10 cycles was done, and the primary endpoint was EFS. And we can see that the number of patients who completed the therapy were balanced between the two arms. Almost in 90% of the patients, surgeries were attempted. In 87%, there was a complete surgery. And R0 resection in those who completed surgery was 92%. So Durva did not add to anything in terms of surgery. And if we see the demographic profile, the gastric and GG junction were well balanced, clinical nodes were present, MSI was not high in 64% of the patients. And so what it means that irrespective of the MSI, patients did benefit, which I'll be showing as how they benefited. So treatment arm of Durva plus Flot, Dr. Shaina, um, what is your take or thought on Matterhorn study regarding these 4 points: pre-stratification factors, eligibility, and those chosen endpoints?
So the Darwa, well, it was a well planned trial. I feel Flot has been the standard, and then among using various immune checkpoint inhibitor, this was a study which added Darvalumab. They have chosen the endpoint of event-free survival, which is a good enough endpoint because obviously OS is what we look at, but then when we look at these gastric cancer patients, we want to make sure that the time at relapse is as long as possible. So I'm okay with that. PDL1, most of the patients were PDL1 positive. So the stratification factor, I think, which they used was PDL1, one of them.
Yes,
So most
90%
of,
was positive, more
yeah.
than 1%. Yes.
So more than 1% and 90% of the patients were PDL1 positive. And so I feel we have a lesser data for PDL1 negative patients.
Mhm.
Maybe this, and also if you look at the confidence interval, it was crossing 1 for the small group of patients, small number of patients in PDL1 negative. So using it for PDL1 negative patients could be a school of thought. Otherwise, I'm quite convinced for using it for patients who have a PDL1 score of 1 plus and can take this because it doesn't add to the toxicity profile. I I think I would use for that group of patients.
Dr. Sachin, what's your take regarding the these points, the treatment arm stratification factors?
I think look, Flot has been the main perioperative treatment for last few years. So this is
Yes.
better than the other regimes so far. So that's why FLOT became the number one regimen to go for if the patient is, can handle the triplet drugs. Now, what has happened? So we have to look in the context and let's compare keynote this 585 with Matterhorn. So then we can better understand this. So what is happening here is that it has a very clear defined endpoint of EFS in the Matterhorn. So keynote lagged that, and the chemotherapy backbone was not, uh, let's say, it was heterogeneous in keynote. So few patients receive FLOT, other receive cisplatin 5FU. So main difference I feel is the in the chemotherapy arm rather than the immunotherapy arm. So pembrolizumab has shown results in so many, across the all the tumor types. It's a very robust data, but it could not give a statistically significant benefit in Keynote 585. But I think it was due to the trial design and a chemotherapy backbone problem rather than the efficacy of the drugs, the immunotherapy as such. So maybe the Matterhorn people designed it better to give that
So
to show
they
that
took the
benefit.
PCR and OS in the secondary endpoint rather than the primary endpoint.
Hmm.
Where
And
Keynote 585,
PCR is good with Pembro also.
yes, that is
PCR
what
was
I'm
not.
showing you in my
Yeah.
slides. That there were three primary endpoints in the 585: EFS, OS, PCR, and the
Yeah.
safety. Four primary endpoints. The
Mhm.
EFS was good, but the PCR did not translate. Oh, so the PCR was good, but they did not translate into a significant
Benefit. Yeah.
benefit in the EFS, and that's what they
Mhm.
did not have the benefit, and they had a negative trial. So that's a very valid point you made out. So, Dr. Jagdeep, what's your take about this trial?
So, if we're going key stratification factors, if you ask me, like we always say that the data extrapolated from the Western, that Asian versus non-Asian is a good in this, that answers our most of the questions. But of course, like majority were the gastric patients, G junction were little less represented in this study as compared to gastric. And other thing, I think other questions
Hi,
have been.
sorry to interrupt, but may I request you to please conclude in the next 1 to 2 minutes as we need to proceed with the next session. So sorry.
I think all other things are have been addressed, which we are talking of these patients, and there is no other thing because all other panelists which they evaluated, I think they are valid points. No other extra additional from my side, I think.
So pathological CR, what we have achieved in Dura plus FLOT is 19% versus 7% in FLOT alone. And as we know from the breast cancer trials, the pathological CR is a surrogate marker for OS. So probably it will convert into OS benefit, which we
So,
haven't.
Dr. Shah, if you ask me in the ISOPAC trial, if I'm not wrong, the PAT CR was close to 20%, like it was pretty less in this. I don't know why this, though we are using the same plot. It was close to 20 to 24% in the ISOPAC trial, but in this it is little less. So bit difficult to what we are seeing with the FLOT, we are not seeing with the FLOT in the Dematron trial arm.
Probably the the demographic might be different. We need to go into details for that. So now the question is, Dr. Abhishek, does adding IO affect your surgical timing? Does fibrosis or anything is affected because of IO? I know just none of us have used, but theoretically, do you think that IO will affect your surgical skills, or it will affect the separations of nerves from the arteries, and or fibrosis would be difficult? Dr. Abhishek?
You're on mute. Unmute yourself.
Sorry, I was on mute. So as we already discussed, we don't have a personal experience of operating patients after immunotherapy. But if we go by the data of the trial, there was no difference in patients who completed surgery or surgical complications. So I think it should not be a problem. Adding immunotherapy, if patient has tolerated well, then there should be no difficulty in surgery. Specifically the lymph node dissection and all, that should not be a problem.
And I think the toxicity effect we all know that durvalumab is a well-tolerated drug and it does not add to the toxicity of chemotherapy. So with this Matterhorn should be considered in perioperative setting for adenocarcinomas patient, especially patients who have PDL1 more than 1%. They have benefited the most. We have the EFS and the PCR benefit both. OS has not been reached, but the trend is towards OS, and we should consider for that counseling in our MDT.
I
So
think
thank
the
you so
recent
much.
data from ESMO, there is some benefit has been shown, I think, with the OS, if I'm not wrong. That has shown that there is OS benefit is there. We have that data literature available, I think, because I have not accessed. I have listened somewhere in some conference.
Okay.
So that they say that it has been shown a OS pattern, and it's a clear cut now evidence to give Metron as what the literature ever evidence state at this point of time.
Okay. Thank you. Thank
Thank
you.
you, sir.
Thank you so much, my all esteemed panelists.
Thank you,
And
sir.
back to Dr. Francis.
Thank you, sir.
Thank
Thank you.
you. Thank you.
So thank you, Dr. Sushant, for summing up nicely and bringing the nuanced points. So next is Dr. Abhinav Navaria. So basically, colorectal cancer, whatever, how much we discuss, there is always something to learn. And precision medicine is there everywhere, and GI is not untouched, so is colorectal cancers. So every time we discuss, we learn more. So over to you, Dr. Abhinav, for your talk. Let's see, let's learn from you. So over to you.
Thank you, sir. Thank you, Mark, for this session. And will you operate slides for me?
Yeah, sure, sir, as you say.
Huh. Because I am not sharing my screen, so you have to do it anyhow.
Okay, I can share.
So as we all know that it is the
One
session
second, one second.
the session is sponsored by Merck, so we'll be talking about cetuximab only.
It's okay. We learned something from there also.
Please,
Their
please
perspective.
share the slides.
Yes, sir, one second.
So precision oncology in metastatic colorectal cancer, looking from the continuum of care perspective. Next slide. So these are the things which we, keep in mind while deciding our patients on in metastatic CRC. So age and comorbidity is the one thing. Then resectability. So as we know that even in M1 disease, we can go for resection in colorectal cancer. This is very debatable topic, primary tumor location, left versus right. The debate has been going on. And again, coming the last and very important point is that biomarkers, the whole oncology these days is biomarker driven. Next slide. So these are the NCCN guidelines strengthening the role of biomarker in metastatic CRC, and we see that whether it's colon or rectal colorectal cancer, mutation testing is must. RAS and BRAF mutation, HER2 amplification, MSI is testing. Then the testing should be conducted as a part of broad molecular profiling because sometimes POL, RET, and NTRK can also be detected. Okay, next. So, ESMO Precision Medicine Working Group and consensus guidelines focus on the following key areas: RAS wild type metastatic CRC, MSI high CRC, BRAF 600. So, these are the types, RAS wild type, MSI high, BRAF V600E mutated CRC. So, liquid biopsy sometimes helps, and emerging biomarkers. Next slide. So, first line unresectable RAS wild type, BRAF mutated, RAS wild unresectable RAS wild type metastatic CRC. So right sided RAS wild type, BRAF wild type. What is our choice for right sided? People do prefer Folfox plus bevacizumab, or maybe Folfinox plus bevacizumab, or anti-EGFR agent with doublet chemotherapy, where cytoreduction is the treatment goal. So whenever we think that there is a solitary uh, liver lesion, we can think of anti-EGFR agent, that is cetuximab. Left-sided RAS wild type, BRAF wild type, our choice is clear that we give anti-EGFR agent plus Folfox or Folfiri. So international guidelines state that RAS testing is mandatory prior to anti-EGFR treatment, and we all follow that. So we're talking about the FIRE 4 trial. The subgroup analysis says that initial cycle with chemotherapy, even before Erbitux, adding Erbitux, did not influence the efficacy outcome in RAS wild type metastatic CRC. Next slide, please. So what is the optimal treatment sequencing with Erbitux? And that is the key to prolong the survival in RAS wild type metastatic CRC. So first line metastatic CRC, start with a chemo backbone with Erbitux to attain the rapid response, then maintain on Erbitux to achieve maximum survival benefit. And after the second line, third line also you can re-challenge with Erbitux upon second line progression. Next slide. So now, left-sided metastatic CRC, anti-EGFR plus doublet chemotherapy recommended as the only option first-line treatment in left side RAS and BRAF mutated metastatic colorectal cancer. So here are the ESMO guidelines: left colon chemo plus anti-EGFR. If there's no progression, continue maintenance. If progression, second line. Right colon, again we have options. Here we can use bevacizumab, or if we want to give the tumor shrinkage, we can give anti-EGFR with cetuximab also. Next. So phase 3 trials supporting the use of anti-EGFR agents in RAS wild type metastatic CRC. We know, so these trials showed overall survival benefit, progression-free survival benefit, and overall response rate with anti-EGFR agents with chemo versus chemo alone. So the trials are Crystal, the Prime trial, and the Taylor trial. Showed OS and overall response rate benefit with anti-EGFR agents plus CT. So here they compared anti-EGFR to anti-VEGF, that is BEV, in left-sided tumors. These trials are landmark trials like FIRE 3 and 4, CAL-GB, SOG 80405, and Paradigm. Paradigm was for panitumumab. Next slide. So this is a typical Merck slide. I mean, first line Erbitux plus chemotherapy, then bevacizumab plus chemotherapy, and then third line again you re-challenge with cetuximab. So Cal GB SOG 80405, bevacizumab plus chemo, then Erbitux plus chemo, then third line. So, so if you see the treatment sequencing, the first is 39.3 months, the median overall survival. In the second way, the median overall survival is 32.6 months, and in the third way, it is third type of sequencing, the median overall survival is 23.9 months. So the slide set suggests that Erbitux should be used in the first line setting. So it gives you the longest overall survival. Next slide. So showing that two trials, phase 3 CalGB SOG 80405, retrospective analysis of patient with RAS wild type metastatic left sided. So the overall survival is 39.3 months and versus 32. So advantage of 6.7 months. Phase 3, where Erbitux plus Folfiri versus Bev plus Folfiri, the survival benefit was of 10 months with a hazard ratio of 0.71. So both trials, the hazard ratio comes out to be around 0.77, 0.71, which is quite good. Next. So talking about the real world evidence has further supported the benefits of anti-EGFR plus chemotherapy in left-sided metastatic CRC. So if we see real world data, a retrospective analysis of around 1400 patients with left-sided receiving first-line treatment in Spain between 2000 2015. So anti-EGFR plus chemo, anti-VEGF plus chemo, and chemo only. So the median progression free survival is 13.21 versus 12.39 versus 9.5, and overall survival is 34.29 versus 28.3. versus 26.59 with a significant p-value. Next slide. So RAS wild type metastatic CRC patient treated with Erbitux plus chemo followed by maintenance chemo. So this is the Indian data, real world Indian evidence. So overall response rate is total is 57.4, left sided 57.5, right sided 59.2. Disease control rate is 69.3 overall versus 69, left side is 67.1, right side is 74%. So the median progression-free survival, if we see, it is 11.1 overall, left-sided is 11.4, right-sided is 9.4. So real-world data confirm the reliable outcomes with Erbitux across left and right-sided metastatic CRC aligned with the major phase 3 trial. So this is Indian data. And I think here we have confusion about the right-sided and left-sided what to do. So I mean this data suggests that for both right and left, first line should be EGFR plus chemotherapy, anti-EGFR plus chemotherapy. Next slide. So first line therapy with anti-VEGF may induce resistance to anti-EGFR. This is what they have shown, that if you use first bevacizumab and then cetuximab, it may induce a resistance to anti-EGFR. So first line VEGF therapy, if you give, it impairs the angiogenesis and induces tumor hypoxia. Hypoxia will induce the RAS activation and independent of the EGFR signaling, and cells then become less sensitive to anti-EGFR therapy because the RAS is activated in a downstream signaling pathway. If the break is there in the RAS, then there's no point in blocking the EGFR path. EGFR. Next slide, please. So bevacizumab, it reduces the number of vessels, reduces the permeability, and 40% less anti-EGFR reaches the tumor cell. So less efficient tumor cell killing. So I think all of us, if we have to use anti-EGFR, we use in the first line. So bevacizumab decreases the tumor uptake of Erbitux by 40% and may have active levels for a substantial duration. That means around 3 to 6 months. Okay, next slide, please. So addition of Erbitux to FOLFOX or FOLFIRI significantly improves the overall response rate of left and right sided. If we see all the trials, almost every trial shows that anti-EGFR is better in the, if you see the forest plot. Next slide, please. So Indian real world evidence reinforces the significant PFS benefit with Erbitux maintenance. If we see, if we continue to give maintenance of Erbitux, there is a 6.7-month PFS gain, and anti-EGFR maintenance validated across phase 2 and phase 3 studies. So here you can see the median overall survival 37 months, and here it is 25 months. So we know, I mean, this data suggests that cetuximab based maintenance should be given. Next slide. ESMO metastatic CRC living guidelines. So again, I think I have done this. Next slide. This was for the right side. So we know that if we want tumor shrinkage, we should go with anti-EGFR. When cytoreduction is the goal, Erbitux plus FOLFOX or FOLFIRI is an effective treatment for patients with right-sided RAS wild type metastatic CRC. So here you can see the FIRE 3, CalGB, SWOG 80P, Crystal Prime. So again, this shows that anti-EGFR, all these trials shows that in the right sided, I think it's yes, for the right sided, when tumor shrinkage is the goal, again cetuximab is doing better. So from the analysis of overall response rate, a doublet plus EGFR antibody therapy remains an option in patients with right sided RAS wild type where cytoreduction is the goal. Next slide. So more patients achieve early tumor shrinkage with cetuximab plus FOLFIRI than BEV plus FOLFIRI again. So if you see 27.9 versus early tumor shrinkage, so 57%, in, while in the BEV plus FOLFIRI 41%. Next slide. So Erbitux plus chemotherapy consistently delivered higher response rate, which correlates with the resectability in metastatic CRC. So if we see the R0 resection rate in first line studies of cetuximab plus CT or bevacizumab, so if we see, so more were with the cetuximab plus chemotherapy, longer survival after R0 resection. So here 21.9 versus 53.9. So of course, when there is more tumor shrinkage, there will be R0 resection, and R0 resection will lead to a longer overall survival. Next slide. So all anti-EGFR, we know two anti-EGFR which we use regularly in the colorectal setting, whether it is Erbitux or panitumumab, but they are not the same. Erbitux can trigger a domino effect immune cascade through NK cell mediated ADCC, leading to changes in the tumor environment, microenvironment, while panitumumab doesn't have that properties. So in vitro data indicate that panitumumab does not induce the NK cell mediated antibody killing, cytotoxic killing. Next, Arbidex is the most well studied of the anti-EGFR therapies with 6 phase 3 trials in first line metastatic CRC, FIRE 3, CAL GB, Crystal, Taylor, strategic trial here Erbitux plus FOLFIRI versus Optimox plus bevacizumab, Erbitux plus FOLFIRI versus Erbitux plus FOLFIRI, differing the maintenance strategy ARMES. So these are the six trials, phase 3 trials in the first line metastatic CRC, while panitumumab has two phase 3 trials. One is prime pani plus Folfox versus Folfox alone versus paradigm is panitumumab plus Folfox or pentamer plus Folfox versus Folfox plus bevacizumab. So, I mean, they want to show that Erbitux has more robust data for in metastatic CRC. Next slide. In paradigm trial, the OS crossed at 28 months. So if we compare, the cross trial comparison is there. So if we see the median OS in FIRE 3 is 28.2 versus 38.2, in CAL GB it is 32.6 versus 39.3. Bev plus Folfox versus panitumumab 37.9 versus 34.3. So they want to show that there is less benefit. There was less benefit in the paradigm trial when compared to FIRE 3 and CalGB. Next. Erbitux results in fewer skin reactions and treatment discontinuation than panitumumab. Yes, that is, I mean, that is what they have studied. So if we know when we are using EGFR, anti-EGFR drugs, skin rashes, hypomagnesemia, I mean, the dermatologic side effects are more. So they have compared that panitumumab causes more skin rashes than cetuximab. Next. And also discontinuation was more in panitumumab than cetuximab. So now what, I mean, for Merck, the challenge is not panitumumab, but the challenge is the biosimilar cetuximab. So if we see, so 9 phase 3 trials, but not a single trial for cetuximab biosimilar. There is a unique mechanism of action that anti-EGFR with ADCC killing. So and there is no proven data for the biosimilars. I mean, all these. So if we see, there are not much data about the biosimilar of cetuximab, but yes, we are using because of the cost constraint. But they want to show that Erbitux is Erbitux, but biosimilars do not stand a place against the Erbitux. Next slide. So, Erbitux is the only anti-EGFR to offer weekly and bi-weekly dosing flexibility and proven efficacy in combination with the multiple chemotherapy regimens. So, if you match the treatment schedules according to patient lifestyle, align Erbitux admission. So, FOLFIRI in the FIRE 3, FOLFOX in the CAL-GB, and FOLFOX-ERI in the deeper. If we see the median all survival, 38.2 versus 28.2, 10-month benefit, 39.3 versus 32.6.7-month benefit. And in FOLFOX deeper phase 2 trial, the benefit is 13.4 months in the overall survival. Next slide. Re-challenge with Erbitux in the third line and beyond metastatic CRC. I mean, first you give Erbitux, and then you give Erbitux free regimen, and again in the third line challenge it with Erbitux. So I will show you the biology. Next slide. So this is how anti-EGFR plus chemotherapy. So the cetuximab resistant clone will increase when you give an anti-EGFR agent free survival, then there will be tumor shrinkage. But the RAS EGFR mutated alleles decline upon anti-EGFR withdrawal, leading tumor to again regain the sensitivity, and again you can challenge it with the anti-EGFR agent. Next slide, please. So Erbitux series challenge demonstrates superior response and survival outcomes over other third line options. So Erbitux plus chemo PFS is 5.7. So I mean, you if you compare it with regorafenib, fruquintinib, and Bev plus TAR-02, definitely re-challenging is giving you a better progression-free survival. Next. Recommendation for targeted therapies in other actionable biomarkers. Next slide. So, other important novel strategy in the management of metastatic CRC subset: anti-EGFR, anti-RAS inhibitor, BRAF inhibition, immune checkpoint inhibitors are for the MSI, and ADC antibody drug conjugates, which are the new thing coming up, and pan multi-RAS inhibition. Okay, next slide. So first line therapy for RAS mutated, BRAF mutated, or MSI high. So if it is RAS mutated, as we discussed in the earlier, the chemotherapy plus BEV or chemotherapy triplet plus BEV remains the option. And if there's no progression, then you continue with the maintenance. Otherwise, second line. BRAF mutated. So BRAF mutated encorafenib plus cetuximab plus Folfox is the first line option. For MSI high tumors, definitely we know whether it could be IO single agent Keytruda or IO combination. Next. The phase 3 breakwater trial is investigating first line encorafenib plus. I think we had a discussion about this. Next slide. So Breakwater met both primary endpoint with twofold median overall survival benefit in Erbitux plus. So they want to include Erbitux plus BRAF inhibitor and encorafenib plus chemotherapy in the first line only. So overall response rate was 60.5.7 versus 37.4. Median overall survival was almost doubled. Median progression-free survival was 12.8 versus 7.1. So this data looks convincing. I don't know when we will incorporate this into our practice. Next slide. So breakwater cohort 3, Erbitux plus encorafenib plus Folfiri. Again, if we see response rate 64.4 versus 39.2. Next slide. Encorafenib plus cetuximab is also recommended of patient with BRAF V600E mutation who have MSI high status. This is quite debatable, but yes, if MSI high, I mean, patient with BRAF mutated tumor and MSI has high status who are receiving first line immunotherapy could also benefit from the Encoraf. But I think first line would still remain to be immunotherapy. Next. 5-year follow-up from Keynote 177 trial supports the clinical benefit of first-line pembrolizumab. Of course, we know that if we see the overall survival, so it is the hazard ratio is 0.73. We can see the separation of the curves. But if here you can see the forest plot, so BRAF mutant and KRAS mutant show lesser activity of immunotherapy. So this was what we were discussing. So I think next slide next slide, please. So data from Checkmate at 8HW showed a PFS benefit for first line Nivo plus EP versus chemotherapy in MSI high metastatic. So Nivo plus EP is now recommended as first line for MSI high metastatic CRC. Next slide. So second line therapy, RAS wild type and EGFR, NAV, BRAF, BRAF mutated, MSI high, KRAS. So this is the flowchart. RAS wild type and anti-EGFR, NAV, left column. You give FOLFIRI. with cetuximab or panitumab, right colon, VEGF plus chemo, BRAF V100E mutated, then encorafil plus cetuximab plus chemo, MSI high immunotherapy, KRAS G12C mutated, cetuximab plus adagrasib, or panitumab plus sotorasib. So this is the flow chart. I mean, this is the ideal condition, ideal treatment options when you have such a patient. Next. Patients with KRAS G12C mutated metastatic CRC have worse prognosis than those with KRAS non-G12C mutation. So, a real world study of patient treated for KRAS mutated in 3 Italian centers. Patients with KRAS G12C had significantly shorter OS than non-G12C. So, anti-EGFR agent plus KRAS G12C inhibitor combinations represent a promising therapeutic avenue for this population, as we don't have the drug in our country. So let's see when the drug comes. Next slide. So long term, okay, I'm not going to go in details. Next slide. Adagrasib plus cetuximab. So the key takeaways: ESMO 2025 living guidelines recommended only anti-EGFR plus chemo as a first line treatment for left-sided RAS BRAF wild type. Erbitux plus chemo offers a survival of around 40 months. On the left side, Erbitux achieved deeper responses, 50 to 60% versus Bev, where it is 30 to 35%. Erbitux is the only EGFR with unique mechanism of action, EGFR blockade, ADCC effect, plus multiple trials. Erbitux based therapy shows lower grade 3-4 skin toxicity. Indian real world evidence confirms it with a 71% risk reduction in disease progression. Erbitux re-challenge is also option. The practice-changing breakwater trial position Erbitux in BRAF mutated also in the first line. Next slide. Thank you so much. Thank you, Sumit sir, for inviting and listening to me till 10:15.
Thank you, Dr. Abhinav. So kind of you. I can see you are tired. You had a hectic day. Still, you are presenting and presenting nicely and giving time to give all the crux points. Thank you very much for staying so long. With this, I think we have come to a good day one discussions, and it was very like every time you listen, there are a few points to pick up. So I will not ask you because any questions because you have already said so many times the relevance in the first line, second line, re-challenge, and in the KRAS mutant population and the BRAF mutant population, which we had a good discussion earlier on also. So thank you very much
Thank
for
you, sir.
staying
Good night.
long. Yeah. I thank all the panelists, moderators, and the speakers who have taken their time out for this discussion and joining today. And Dr. Vikas Talreja, I can see your name there. Though you had no presentation today, thank you very much for joining. Really great for you to be here. And thank you, uh, uh, the team, the technical team behind this. Thank you, Dr. Sachin. And thanks to Mrs. Ekta, Yash, and Gitika, and the tech support for making this possible, and all the sponsors for making it possible to give us this platform to interact. With this, I think we'll conclude day one here. Thank you very much. Good night.
Thank you, sir.
Thank you, sir.
And good night, sir.
Good night.
Good night, sir.
Okay, so please join day two also. So thank you so much, tech support Yash, for the support. Thank